Professor, University of Rochester, Eastman Institute for Oral Health in New York, USA. Associate in Dentistry, Faculty of Dentistry, University of Toronto, Clinical Instructor in Prosthodontics, Department of Dentistry, Mount Sinai Hospital, Toronto Private. Was I correct, Sinai? Or
Mount
Sinai?
Sinai, yes.
Sinai,
Mount
yeah.
Sinai, yes, yes. The Mount
Okay,
Sinai.
and Mr. Leon Gergov is a colleague of Dr. Beg, and we are very happy. We always see them together. So please, the screen is yours. Please start your presentation.
Okay.
Thank you so much. Hi,
Thank you.
everyone.
So, second, let's share the screen. So, Doc, can you see your screen right now?
Yes, yes, everything is okay.
Okay, just give me 10 seconds, Leon. I think we need to put the computer down because we don't have the mouse.
We have, okay. No problem. It's good. Just sit down. Yeah.
Okay. Perfect. So we're good. So can you guys hear us very well?
Yeah, everything is okay.
Fantastic. Okay. So first of all, good morning, everybody. Thank you so much for having me and Leon in your symposium. And I'm very happy, Dr. Farid, she's been very instrumental to organize these kind of programs. And this is my second time I'm taking part into this. And last year I really enjoyed, and I'm sure you're gonna have a good time as well. And I'm sure yesterday was a fabulous presentation by all the esteemed speakers who were there yesterday. And I'm sure today you will also have a good time, starting from 9 till whenever it ends, maybe around 4 o'clock. I saw like a full spectrum of programs lined up and with very interesting topics. So I wish I can stay awake all the time and able to attend, but I just came back from Rochester. Leon was here, so we kind of came here together to able to do this program. Okay, so welcome you all again. So today we're going to talk about prevention through planning. So basically, when Dr. Farid asked me, Dr. Beg, give something very interesting for people to look at things and how you look at dentistry from a perspective of implant restoration. So we're going to talk about what should be done, what not to be done, how you look at the case, why it's very instrumental to plan cases when you have a multidisciplinary approach. Okay, so that's going to be our main goal of discussion today. Okay, let's go. Again, Dr. Farid gave a fantastic introduction. I just want to recap again. I'm part of 2 universities, one in US and one in Canada. And I teach in a hospital, so I have a very hectic schedule. Apart from that, I definitely like to be part of education institutions because it's very comforting. And I always believe that when you teach, you learn more than you are really offering education. So I tell my students, I'm here because you guys are going to teach me something new today. So definitely being part of institution makes a big difference. And it's just fun. Teaching has always been fun. Again, we all have to pay bills, so we have to still have a private practice. So this is my office. Right now, this is where we are sitting right now. This is the place. It's called Dental Specialist Group. Leon and I work a lot here. And especially the video, what you just showed, Dr. Farid, it's fabulous. It shows an amazing journey about how back in time, that how much advancements things have happened in a medical technology perspective. Dentistry, definitely, we are in one of the best times of the generation where we can really have so much technology now in dentistry to be able to do some fantastic treatments. Dental implants have been a big part of practicing dentistry, but unfortunately, things can go south and things can happen where we definitely have to find out what's the best possible way to be able to manage different types of complications. Obviously, we don't want to get through this. Like, for example, if you look at the screen on the left side, There's a lot of treatments has been done with lack of having a vision on the case. So today's my biggest focus is how to prevent things not going south when you have a proper planning of treatment for the cases. So prevention through planning, that will be our goal. So dental complications are not unusual. Actually, most of the time now I see that there are some publications coming up in literature talking about what's going on and how things has to be managed. But we have been very fortunate because this has been one of the biggest treatment options for patients, especially when they're missing a tooth. So I'm not saying that this is not the best option. This is actually a fantastic option. Like, for example, if you look at this article's latest up to like 2014, I'm sure there's more latest literature as well to support the statement that from a survival and success rate standpoint, dental implants, especially almost like 97% of success, and especially the restoration or the implant survival or a success rate. But they did talk about failures, that failures do happen, but the very negligible percentage of failures happen with these kind of restorations. But again, this is where we will be focusing today. So my focus of presentation is not on the 97%, but focus will be on the 2.5%, 3% of things, what happened and why things went wrong and why things has to be managed so that we get at least a 99% success rate, okay? So do these things really happen? Unfortunately, they do. When these kind of situations happen where you have issues with restoring implants, then obviously you're always relying on other people's expertise or your own expertise to see why this situation has happened and how would you manage situations like this. My biggest take when it comes to multidisciplinary treatment is I personally feel that there is lack of major ineffective communication. Now, most of you are based in the university. You're blessed to have the opportunity to work with other departments so that at least you can collaborate and work with each other. But when you end up in a private practice setting, sometimes when you do not have in-house specialists from different specialties, then the problem is that might be one of the big reasons why you see implants surgically in a prosthetic management is not happening to the optimal care what you are expecting them to happen. So ineffective communication has been a big part of challenge with our patient management strategies. For example, if you look at these two patients, they both are smiling at you and they look happy. But if you really look at these patients, one of them has implants as a treatment of choice as restorations. Now, the lips are really masking all the problems and concerns what they have. When you take the lips away, obviously the patient on the left side is dentate patient with all beautiful natural teeth, but on the patients on the right side has a full comprehensive full arch implant-based restoration. Now, the patient on the left side is 30-year-old, the right side patient is only 40-year-old. But it's not fair for the patient on the right side to see what they have to go through, how poorly implant planning has been executed, how poorly prosthetic management has happened. So you can imagine on many levels, this patient will have issues maintaining good optimal oral hygiene, having a long-term success with these implants, not having any recession or bone loss. So these challenges can become down the road where patients can have issues where they can record some kind of failures of these patients. Now, obviously, we want to have more robust prosthetic designs, as you see on the left side of the screen right now, where another patient who has an implant reconstruction, but the prosthetic management, the surgical planning is definitely much better than the patient who was seen in the previous slide. Now, when you talk about implant-based restoration, there's always a strategic planning for picking up the choice of restorations, what we're looking for. For example, if you want to do a screw retain restoration or a cement retain restoration, this choice is purely based on multiple factors. For example, the ease of maintenance, what exactly aesthetic outcome you're looking for, the design of the occlusion, how much intraocclusal space you have, how easy the prosthetic design is, cost of the whole treatment process, implant position, angulation, how well the patient can open the mouth. So all these factors definitely plays a big role when you make a choice between screw versus cement. But in this study, they found out that definitely irrespective of using the choice of restoration, we definitely run into some kind of prosthetic technical complications. for example, screw loosening or fracture, chipping, repairs of porcelain being done, framework fracture. So they have seen, irrespective of the choice of restoration, these things can do happen. Okay. So on a comprehensive level, just to keep the conversation very simple, I kind of divided the whole prosthetic complication to 3 different categories: biological, technical, and aesthetic, so that at least you guys can understand on a much more easier way to see which category is the most challenging one. Now, I'm not going to spend a lot of time on biological complication. That is more about implantitis or peri-implantitis or peri-implant mucositis. That's more a surgical side of implant dentistry. So we'll talk more from a prosthetic management from an aesthetic and restorative standpoint. So that's where me and Leon are going to be focusing our conversation today. Okay. So as I said before, our goal is to discuss more about how can you prevent problems down the road when you have a proper plan in place. Now, we all know one thing is implant dentistry is purely driven based on restorative treatment. So when you talk about restorations, the biggest concern, what you want to really incorporate is how much physical restorative space you have for these restorations. Now, some of you might be students. When I was doing a prosthodontic program, Dr. Gerald Grazer, one of the biggest names in prosthodontics in North America, he told me, Bobby, no space, no prosthodontics. So you have to have the required space for prosthodontic management. So I'm sure Leon agrees with that as well. And him as a lab, if there is no space, he's going to say, okay, you have a beautiful implant restoration, but I'm going to provide you a final restoration when I cannot manage this case. So that's the reason is complete assessment of the sites prior to management of dental implants is very, very critical for a long-term success. Okay. It's a very good mission statement. If you fail to plan, you are planning to fail. I think this 3-line statement makes a big difference. When Benjamin Franklin mentioned this, I'm sure we always really incorporate this, not only in dentistry, in every aspect of life, right? So I hope we all take a big message from this 3-liner statement, okay? So let's start with one patient, very young patient, beautiful looking girl, 27-year-old, comes with her mom, and she was referred by one of the general dentists. And she said, Dr. Beg, I want to have a better solution for my daughter. My daughter has a missing tooth. I want you to see what best you can do. So this is the case. I'm going to take you through a journey of treatment, what we did and how challenging this was for us to manage on this patient. Because a lot of times when specialists are involved in a case, I wish we were involved from day one, but unfortunately, we always get to see the patient halfway through the treatment, and then we are really struggling to manage the patients.
Not always we get to see them. If everything goes well, they don't send it here.
There you go. That's so true. So if you compare her smile from the left side to right side, she's beautiful looking teeth, but we're definitely missing a single tooth. So what happened to this case? So this is a frontal view without the lips. You see the gingival architecture, the color of the teeth, the shape. So you can tell right away that this is somebody a healthy patient. From a side profile view, yes, patient lost the canine, but the left side canine is still intact. Patient had impacted canines, and from an orthodontic treatment, these canines were brought into occlusion. But unfortunately, the way orthodontic treatment was done, patient ended up losing that canine because there was massive buccal and lingual bone loss for that patient. An occlusal view to see how the amount of existing available bone is present for this patient. For example, if you can see the buccal lingually from a Cbct classification, this is class 2, where you don't have not only vertical height, but also you have the buccal lingual deficiency as well. So placing an implant without any kind of augmentation can be quite challenging. So obviously in a patient like this, when you're not going to have existing volume of bone available for doing dental treatments, the first thing what you plan to do is do a CT scan to see what's the best available amount of bone for this case. And for example, you can see here, tooth number 1-3 is missing on a cross-sectional view. There is some available bone there for this patient, but definitely there might be some amount of bone grafting might be needed at time of implant placement surgery. But that's not my problem here. My problem is more intense, not only the single missing tooth. Look at this case. Now, that's the 3-2 situation. Now look Now look, sorry, 1-3 situation. Now look at the teeth number 1-2, the lateral incisor on the upper right side. You can see in the lower cross-section images, you can see already, barely this tooth is being held. There is a lot of apical root resorption, which is one of the classic complications or downside of orthodontic treatment. There is a possibility that there might be rounding of the roots and the loss of the apex of the roots as well. Now, in this case, there's any barely held anatomically on the root surfaces which can provide any kind of stability. I personally feel the lingual attached wire, orthodontic retaining wire, is basically trying to help 1-2 in place to see that is to keep it minimize the mobility of the tooth. But I think once the wire is removed, that tooth will have at least grade 1 mobility, or maybe more than that. So we already know the answer that the patient is going to lose tooth number 1-2 as well. Now, this is the picture before the tooth was extracted, and this is the picture after the tooth was extracted.
Wow.
Now, I can definitely park a car there, okay? Unfortunately, this is very scary picture for a patient and for the doctors who are involved in the case too. So if you really want to make a measurement of the space, there's a massive vertical and horizontal defect. How many of you want to take this patient? I will be very happy to transfer this case to the University of Tehran, the Department of Prosthodontics, Dr. Farid.
Yeah, we see sometimes this kind of patients. Yes, we have some like them too. But do you have enough space both for the canine and lateral incisor? You know,
yeah, that's a very good question. I will answer that in the upcoming slides. So now we're not only dealing mesodistal space, but also we have a massive vertical defect as well. So, and again, obviously this is a multidisciplinary case, and I work with a surgeon, Dr. Joe Friedlich. He's a very known oral surgeon in Toronto. I said, Joey, listen, this is a very complex case. I want to be on board. Let's work on this case together. So he did vertical and horizontal augmentations with the broad grafting. So you can see in the cross-sectional view where he has done the surgeries. And again, now he not only built up the vertical length of the site, but also you can see the fixation screws, which are radiographically visible in the cross sections of the image as well. So now the original.
Sorry, excuse me. Can I interrupt and ask question or not?
Sure.
What kind of graft was used? Because I have heard that vertical grafting is not stable. You have a lot of resorption after a while. What kind of grafting is that? Is it autogenous?
This is the autogenous graft. He did a chin graft. Yeah, that's a very good question, doctor. That's the reason you can see the fixation screws. So we did not do allograft here. He used the donor site was the chin graft, and also sometimes they take bone graft from the tuberosity as well, or ramus of the mandible too. And the other harvesting sites can also be from a hip as well. But because of the size of the defect, what we have, he felt that maybe intraoral will be a better site for harvesting the bone graft. Now, autogenous bone graft are much more predictable, but we all know the answer that there's always going to be more than 50% vertical loss, even if you're doing vertical augmentation. And again, I'm not an oral surgeon, so don't count on my statements, but I'm just telling you what happened in the case. So definitely vertical grafts can be very tricky, and the flap management can be challenging, and there might be more than one site where patient can have to go a surgical procedure. So we have to really inform the patient that we're not only working on the affected site, but there is another site where we need to harvest the bone, and the patient morbidity will be there in those kind of situations. So the augmentation is done. Left side is what the original side, but right side is how we definitely see some amount of vertical enhancement of the bone compared to the previous sides. But again, we do not get a complete closure or height what we're looking for, but definitely we enhance the amount of the volume of bone which was needed. So what you see on the right side is a radiographic template made by Leon. So he made me a template so that we can do a CT scan, because we want to know precisely where we want to place these implants. But keep in mind, this case was done a couple of years back. Now we can definitely use digital diagnostic tool setup to see how we can able to know where exactly the teeth emergence is going to be. But sometimes in complex cases, I like to do like a normal diagnostic tooth setup. I want to have more precision planning about the case, so at least I know where exactly this teeth gonna be, rather than just relying on a digital diagnostic tooth setup. What do you say, Leon?
I agree with that because, even though that with the technologies basically these days that you can basically do a digital setup and right away align it with the trios and let the patient go with that, with that diagnostic, you don't have to send it back to the CBCT because they already done one. We can cross-align all of them. And again, it all depends on the situation. So for example, for her, because you want to actually go and see the emergence profile in the buccal wall missing, because you can see from the picture on the left, we're missing a little bit buccally lingually. So we will have to build some pink ceramic to restore that deficiency in the bone, even though the bone graft was done with the mesh and the lingual screws,
So obviously we already know the answer when you do bone grafting, and the most important thing is patient always look for replacement prosthetics. So the biggest goal from a surgical standpoint is not to provide any kind of prosthesis which can create some vertical pressure on the graft side, because the biggest challenge would be we don't want to lose the amount of bone grafting was done. That's why there will be some kind of replacement prosthetic. For example, you can see here an S6 style retainer, which is just connected to the adjacent teeth, and it's a removable type of prosthetics where patient can take it out purely for aesthetic reasons. We're not making any flipper or posture denture, which is providing some kind of replacement prosthetics until we have some basic healing of the surgical side. And again, after that, we know that on the CT scan, we have the amount of volume which is needed for the bone. So we created a surgical template because the surgeon wants to do a conventional surgery. Keep in mind, oral surgeons are great, but they really wanted to follow the protocol of conventional surgery because the amount of bone loss happened. And also, Dr. Friedrich has to remove the fixation screws prior to placing the implants. So he needs to definitely remove do a full flap management in this case. So we are doing a conventional implant placement guide in this case. And after the patient healed, we provided a flipper for the patient as an interim replacement prosthetics, because now implant surgery is done. So we can definitely look into the options of doing a conventional flipper. So if you look at here from a frontal view and two lateral views, look at the existing gingival architecture on the left side. So we are missing some massive pink defect here in the patient. So able to provide some kind of restoration is the first step, what we wanted to analyze in this case. So what we did is implant-based temporization. So you can see here, we have a 2-unit implant temporization connected together. But we also tried to see if we can do like a single unit, how much amount of missing pink porcelain going to be there compared to connected prosthesis compared to a segmental prosthesis, because we want to provide both the options for the patients. Keep in mind, guys, patient is only 27-year-old. So there's a long journey ahead of this patient. So we want to give every option possible, because as long as the prosthetics are cleansable, that's the only time we can maintain the existing architecture levels of the bone and the soft tissue, so that down the road, we don't have any kind of recession and bone loss. That's why we want to try them in temporization phase. And once that is done, this is the final restoration what we made. Unfortunately, we could not have splintered prosthetics because of the amount of pink porcelain which was missing. And we have 2 abutments with screw retain abutments with the cemented crowns on a 2-unit bridge. So talk about pink layer. So
basically, is looking at that picture. Unfortunately, we decided to go with cementable, even though she was a young patient, due to even though the surgeon, an oral surgeon, did the bone grafting, he still did not have enough bone to place the implants more palatally. So basically, the way he placed it where was more bone. So we had to go with custom abutment, which we then did the gold hue. And on top of them, then we cemented those prostheses with some pink. Now, as you can see on the pink doesn't start all the way on the lower picture from all around. We went just from a case, so when it presses the tissue, it will almost look as one piece with the natural gingiva that the patient have. So looking at that picture and the abutment that you've chosen, we decided to go with Atlantis, custom abutments, and then on top of it, 2 splinted units together. Now, there is another way that we could have done. It's like 2 single crowns on top of those abutments and the pink tissue on the abutments. Then the problem is because she had a very high smile, it would show a very gray effect around. So that's why we decided to do it just like that instead of 2 single crowns on top of those custom abutments.
Wasn't it better to have one implant in the position of canine and then cantilever the lateral to it? Because I think aesthetically it would be better. Don't you think so?
Very good question, doctor. Yes, we explored that option as well. We could have done a canine with a single cantilever, but because of the size of the defect we had, we could not take such a big risk from able to just to have a single implant restoration. Now, look at the amount of pink which needs replacement and the amount of prosthetic design and everything. So as we make progress in the presentation, you will see how we need implant in the right place, right location, and how we need to prosthetically manage. So yes, we could have looked into that option as well, but we kind of went to the option of doing two separate implants because mesiodistally we had the space. Yes.
And beside the mesiodistal space, we had the problem with that even if we would put one implant with a cantilever, she would still have a very big defect, which eventually will progress throughout time, because it's not like from the orthodontics that she had, all her other roots was still very short. So we were kind of trying to preserve the other bone side that we have by placing 2 implants instead of 1.
Oh, yeah.
So this is the final restoration, the smile. Good thing is the patient has an average smile line. And you can see on the picture on the left side, right side, where she's a very young girl and she has to go through so much. Unfortunately, orthodontics backfired in her case, and her 2-3 also has a very similar situation, but we are very carefully managing 2-2 and 2-3 so that we don't end up a situation like 1-3 and 1-2. Now, this is a picture done in 2018. It's been 4 years now. Patient is good. We do not see any bone loss or any recession. We've been following this patient for the last 4 years, and things are very stable. So this has been a very challenging case, and we are able to manage very carefully, and we are able to maintain this one in long term. So another patient. So basically, the reason for just want to show you between these 2 cases is that their similarities. Why is very critical from an orthodontic perspective that we are trying to manage these patients. And again, unfortunately, sometimes things doesn't go the way we have planned. Now, if you look at her, she has a high smile line, triangular teeth, long interproximal contacts. You see the gingival margins are extending almost up to incisal 1/3. So if this patient has one single tooth missing, this can be a quite challenging patient. Now let's look at this patient. This is a profile picture for her, left side and right side. Now, looks like a very similar case like our previous patient. Now, if you look at more closer pictures of this patient, look at how beautiful her teeth are. Soft tissues are very perfectly lined up. She had to do orthodontic treatment because she has a deciduous canine, she's congenitally missing canine, she had an issue. Now, look at the size of the box defect we have here. Now, her teeth are triangular shape, but her defect on the missing tooth side is completely box shape. So cases like these can become quite challenging because you can provide, as a prosthodontist, I can provide a beautiful restoration, but how would I manage with these patients with replacement of interproximal tissues? In the previous case, we had 2 teeth missing. We are barely able to manage. In this case, it's the 1 teeth situation. Now, this case is not completely done yet. We're still working on it, but just to show you the issues, what we can run into as a problem when you're not going to have the right amount of volume of supporting in what you call interproximal tissues and the bone levels and the bone loss, which can create challenging for the prosthodontic management. Now, if you look at the recession on the mesiodistal of tooth number 1-2, you can already see the CEJ, the cementum is exposed. It's almost like 3 millimeters below the CEJ is where exactly the bone is right now. I mean, the soft tissue right now. Now you can do your math where exactly the bone level is going to be, add another 2 to 3 millimeters. So these kind of patients can be always going to be a major issue. Just to show you from a radiographic perspective, how the canine was and see the type of the defect. We have an angular defect here, and there was some degree of bone grafting done after the tooth was extracted. You can see the fixation screw. but definitely we still ran into issues able to manage this patient. Okay, so we're still working on the previous patient. Patient number 3, same thing again, orthodontic treatments were done, canines were lost, patient's tooth alignment was placed in such a way that we did not have any space for this case for able to do. Yeah. So patient has no canines, 2 laterals, 2 central incisors. All things were done was the spaces were tried to be closed by creating some kind of illusion with placing composites. Patient was not happy at all. She complained that people can see my smile. It's very obvious. Unfortunately, I'm not happy. What options can you guys provide for me from a prosthodontic perspective? My biggest challenge here is the mesodistal space is very minimal. The root proximity is also in very close proximity to each other. We do not have enough adequate space for a canine implant. So I had to, with great difficulty, convince this patient that, you know what, I don't think what we can do anything much here right now, because I don't have a panoramic radiograph to show you. She also has the same issue, very short and blunt teeth. If you start moving this teeth, she will lose more teeth because of the amount of crown root ratio what she has. So anytime we have orthodontic treatments done, I always recommend and request my orthodontist to involve me, not when the patient is 19-year-old, when they start orthodontic treatment at age 12. Yes, I'm not involved in the case. I'm not doing anything major, but at least I'll help you to see how you're going to be doing space management, so that once the orthodontic treatment is done, when implants will become part of the treatment protocol, at least me as the prosthodontist and the surgeon can help the orthodontist to able to provide a reasonable, decent restoration. A close-up view to show you, we don't have any space in this case. This is very quite challenging because we do not have any replacement space for those canines. Okay. Next patient. So just to show you on a model. So anytime you have a patient like this, especially from a general dentistry standpoint, you get very excited. Oh my God, I have a patient who's missing a couple of teeth. I can place implants and we can do reasonable restorations. Yeah. But we need to analyze in more detail. Like for example, if you look at this case, patient is missing both the first molars, right? Now let's look at this, what happened. The maxillary molar on the right side is supererupted. The second molar is mesially tilted. Yes, you have the implant space what you need, but definitely there is an occlusal space discrepancy here. On the left side, you can see the maxillary left molar is almost riding on the distal edge of the mandibular second molar. Now, that's not how we're going to be designing the occlusal scheme. Now, the moment you see something like this, you already know the answer that this is not a single tooth missing situation. This is more than this. This is what I'm trying to explain. Prevention through planning. We need to plan our patients so well that we're not going to run into issues after we place implants and trying to figure things out. Okay. Just to show you more close-up view, what's the best way is, we have Leon make models, do diagnostic wax up to see how much orthodontic uprighting or needs to be done, or distalization of the tooth. So based on this, you can able to communicate with your orthodontist to explain to them how much space management you need to do. For example, in this case with 3 missing teeth, but now see how big this case become. Lab, prosthodontist, orthodontist, surgeon, everybody got involved. But you're saying only 3 missing teeth, why so many people have to be involved? But you can see the case is definitely a multidisciplinary case in spite of having a single tooth missing situation.
The reason is,
do you do orthodontic treatment for the second molar right side? Do you do usually orthodontic treatment for these cases?
Did we do? Yes, I don't do by myself, but definitely we will refer this patient to an orthodontist and we work with them to able to provide the orthodontic treatment. So I'm going to show you in upcoming cases how we manage these kind of patients. A wonderful lady, she's missing single molar. Again, you can see same thing again, single tooth situation. What do we see here? Mesially tilted molar, supererupted maxillary molar. So the intraocclusal space is very, very minimal. So what are our options in this case? You can always say, oh, why don't we make a crown on tooth number 4-7, make a single crown on 1-6 and get the space what you're looking for. But that's going to be more aggressive on this patient. So there's a possibility that you might have to do crown lengthening on 1-6, because you wanted to establish idle plane of occlusion. But if you're using orthodontics as a treatment, you do not have to create major challenges or treatments on the remaining teeth. So let's show you what we did. In the same patient, she's missing teeth on both sides, both the molars. What we did is the orthodontist placed tags, temporary anchorage devices on the maxillary arch between the molar and the bicuspid, and this maxillary 1/6 tooth has been intruded using the.
How much was intruded?
So we intruded almost like 2 to 3 millimeters, doc, to create so that we can establish idle occlusal plane. And the lower right side molar was uprighted by using the step wedge technique, and by intrusion, orthodontic is happening at the same time, maxillary intrusion and uprighting of the lower molars. So by doing this, we got the space what we need. Not only we made the space what you're looking for, we also established the idle plane of occlusion. Keep in mind, patient was only one missing tooth, but see how we look at things from a different perspective, so that on a long term, we don't have run into issues and create problems for the other teeth.
Which is a black triangle, food stock, and all that. Eventually, yes, we could have just went forward with just restoring it with a couple of crowns and prepping the other teeth, which you can see that the other teeth did have some heavy cavities and some occlusal fillings. So we can basically just prep them, and then, but again, we always try to go into preventive dentistry and try to prevent any type of like troubles down the road, because all of them are still pretty young patients.
Okay. So every time you do dental treatments and we plan restorations, obviously we have to think outside the box. I know we do a target specific dental treatment, but sometimes we misdiagnose cases and we run into issues. So I'm going to show you a whole bunch of cases now, how things did not hit the right target and they all were all over the place. Okay. Now look at these two radiographs in the case. Okay.
So looking at those pictures, as you can see on picture number left, implant was placed, and then there was implant migration, and it was whenever it was placed too close to root number 2-1. On the right picture, which you can see that there were placed 3 implants instead of 2 implants, while the planning is why did they place 2? Because the first one that they put on the lateral, they felt that there was not stability because it was too close to the canine. Now the thing is, you can see that all this happens due to the lack of planning, the lack of ideas. Now the problem is, whatever we look, it's only an X-ray. When we have to take an impression of this, do you think those impression copings are going to sit passively? No, they're not. They're going to be bumping into each other. So restoring that case, it's not going to be as easy as just putting 3 abutments and maybe 3 single crowns, or maybe a 3-unit bridge. We'll probably will have to come up with an idea of maybe doing a small bar and then a secondary structure with all of them together, due to the lack of space. So the lack of planning in this situation will cause Dr. Beck to be more paying attention when he takes the impression, me too when I do my final prosthesis. And again, we might even have to go into like secondary structures, mill type of abutments with an angulation from a custom abutment milling centers like Panthera and all of those companies.
So that's why I said, if you do not know where you're going, you'll end up somewhere else. So in this case, the planning was not a big part of what they're doing. It's just a surgically planned case for prosthetic management. I don't think there was any communication done, or maybe any kind of guides were used to provide the surgery during the time of surgery. Another case. So patient, when I saw this patient, like, okay, what's going on? Dr. Big, I have 2 implants placed, and somehow my dentist said, oh, I'm going to only restore 1. I said, okay, so then I took some radiographs of this case. So if you look at this patient right now, we have a single molar being replaced, but we have 2 implants. So what's the distal implant doing? So obviously looks like this distal implant is providing some kind of molar support, which is supposed to supply more molar support. I guess, Leon, I think right now it's only doing a molar support.
Yeah, basically it's just only molar support. And you know what, a lot of the time is when a surgeon places an implant without thinking, for him it's a lot cheaper just instead of taking the implants out, he's just going to place another implant beside it to get more stability. Now, could me and Dr. Beg restore that implant? Yes, we could have done one crown with two type of abutments to make it like a molar with two roots. But then the question is, how is the patient going to clean it? Like doing whatever we did not do that, but let's say if we would have to do it, the patient at least can go there with a floss and clean it. But let's say we do one molar with two roots with the hope that it's going to last. Yes, it will last. Yes, it will survive, but is it going to be a success? No, down the road, he's going to lose the tooth behind it. Lack of planning.
So eventually the patient lost the molar, and that molar was not able to be restored. So let's see what exactly happened in this case. So patient had canine, 2 bicuspid, first molar and second molar. That's normally teeth. Down the road, patient lost 2 teeth. What happened is the second molar mesially drifted, shifted, and tilted. Because of the tilt, we have a trapezoidal shape space. Now, for surgical planning, all we see is a big prosthetic surgery. Sorry, from a surgical planning, you see the available space from a surgical standpoint, but the prosthetic space was not properly analyzed. So probably this could have been a better plan by doing some degree of orthodontics and really uprighting the posterior molar and then place 2 implants strategically, rather than clubbing these 2 implants together. And they ran into issues able to restore this case. That's why they end up doing single implant. Patient asked me, I paid for 2 implants, but they gave me only 1 crown. Can you please answer this question? I didn't have a reasonable answer to give to her because I don't want my colleagues to look bad. That's why I have to wave up the answer and then explain to her this is the best option what you have right now. But again, we could have definitely planned better in a case like this. Okay.
Perhaps they could put 2 narrower implants. One of them is the diameter is too much. I think the left side is better because it is narrower. And,
an immediate placement, he extracted the tooth with the tooth.
No, they did it.
Immediate replacement.
Yeah. No, the socket preservation.
He did the socket preservation.
Yeah, there was a socket. I can see it radiographically. Yeah. But again, we can spend the rest of the afternoon on this one slide because we can find a lot of things. Definitely from planning perspective, it's very poor. Yeah. The mesodistal spacing of the implant was not ideal as well. Now, next case, you can see here a patient on a panoramic radiograph. Eventually, because of the size of the post and also the root canal treatment, tooth number 4-6 is on a compromised state. So that tooth has to be extracted. So patient ended up losing tooth number 4-6. Now you might be thinking, okay, it's very good. Single molar missing. Let's place a single implant and provide a reasonable restoration. I said, I think there's a little bit more than this to the story. So I said, you know what, let's check at this case. So what are we looking at here? The bicuspid. So if you really look at a periapical radiograph, this is what you're seeing right now. You have a large extraction site, and then is a bone grafting of socket preservation has been done. But the bicuspid is not in the most ideal space. It's really tucked up under the distal surface of the tooth number 4-4. Now, are we placing a single implant to replace 4-6, or do we have to take help from orthodontics to be able to manage and take care of this case? So you can see here technically what happened. This is how it's supposed to be. This is the molar space. So this is what the ideal alignment, what you're looking for. But if we have to place implants to align these kind of teeth, then obviously we have to incorporate orthodontics in this case. But if you do not look into orthodontics as a part of treatment and just place an implant in the 4-6 side and ignore 4-7 and 4-5, we will run into issues down the road with management, surgical planning, foot impaction, you name it, any kind of prosthodontic issues, what we can run into. Okay. Other case. So bone grafting was done, and we see all this kind of fixation screws. The funny thing is, when I saw this picture, like, wow, probably whoever did the surgery, they were actually living very close to a hardware store, and they brought all the hardware from there, and they pumped in all of the screws into the implant. Now, fixation screws has to be removed prior to implant surgery. Now, if you have these many fixation screws, I don't know what's the remaining amount of bone available to place an implant. Definitely, communication has been missing. Surgical planning has been not to the most optimal level.
Was he trying to keep the membrane in place? So what was the idea behind
I
it?
have no clue what he was planning in that case.
Uh,
Yeah. Look at the other case. When I saw this radiograph, patient has a 3-unit bridge. Hold on, what am I seeing there? Patient has 2 implants which are not restored. And then probably they could not make impression. They end up doing 3-unit bridge. Now, what a big loss for this patient. Spend money on surgery, extraction of the tooth, 2 implants, and final treatment option was no implants were used, 3-unit bridge was done on the teeth. So this was definitely a poor approach to treatment planning. I'm sure they could have done a better job by not placing 2, maybe placing 1 in the right place and not able to do a bridge for this case.
So there was 2 implants, but a pontic over there.
Yeah, so they basically did not use the implant at
They
all.
did not use the implants. They left the 2 implants and did a 3-unit bridge on the teeth.
It's
That's
interesting.
like new technologies. We place the implants, but we do not restore them.
That's so fun.
You know, you see those things and you're like, okay, what could have possibly gone wrong? Like, why would the dentist do it? And that's what I mean. It's like, if everything goes well, they don't send it here. It's only when everything goes sideways,
Yeah.
then they send it. And when me and Dr. Beg, so sometimes I'm not constantly in this office. My lab is a little bit further down the street. So Dr. Beck does sometimes FaceTime and phone calls with me, and he's like, "Oh, look at this," and we don't know if we rather laugh or we are just like sad that we could have done it the first time around so much faster and so much better to the patient, that when you see this, you don't really know how to react because you feel sorry for the patient. On the other hand,
broken screws. That
Yeah,
are
I see some broken screws as well. I'm sure they tried to do some kind of prosthetics and they couldn't manage. They
Yeah.
gave up and probably did a 3-unit bridge. So now it's a big topic on its own.
3-unit bridge with an open margin. No, it's not just 3-unit bridge.
So look at this case, single missing tooth. Patient was referred, external hex, Branham mark, broken screw in there. And guess what? They couldn't manage to remove the broken screw, and patient came back again, and I see a 3-unit bridge. I said, wow. So for me, the biggest concern with these patients is, yes, you have provided a 3-unit bridge on this patient. How would you manage the soft tissue closure on this case? On my personal experience, and again, I'm not a surgeon to comment on this, but I have always seen you're not going to get a complete soft tissue closure by just removing the prosthetics, which was fractured. Some kind of surgical approach has to be done to completely close up the soft tissues, because keep in mind, I have seen the small, tiny hole aperture opening where you can see in my next slides, they ended up thought that things going to stay stable, but this is not what happened. Now they end up doing this case with a 3-unit bridge, but definitely this implant will continue losing bone, because there might be some oral communication with the soft tissues and the implant prosthetic platform, and that eventually collects foods, and this implant down the road can be a big failure. Look at the length of the implant. Implant is almost like 3.75 diameter Branham mark implant. It was not should be the choice of implant in this case. So poor selection of implant design, poor implant platform planning, and again, I'm sure occlusion was an issue.
Yeah.
And then a lot of things were not paid attention. That's why they have this prosthetic complication, and they end up doing a 3-unit bridge on this case.
They couldn't even put a cover screw on top of it because the screw from the previous prosthesis was still in the implants, basically.
They couldn't take it out?
They couldn't take it out. So when they cannot take it out, and it's funny because everyone knows in town that Dr. Beck is the best removing broken screws. Like if anyone messes up a broken screws, they send it to him. He does this. He has 1 day a week dedicated only removing broken screws. And the funniest thing is they already restored it with the bridge on top. Now the patient is like, oh, I'm not sure. I keep having pain under my bridge, but we cannot cut the bridge. The bridge was done. Now cut the bridge and then risk it not giving it to him. So usually, well, in those cases, we have to refer it back to the dentist who did it to come to some arrangement with them.
Sometimes, excuse me, I'm interrupting again. Sometimes it would be better to use at least Maryland bridges rather than to fully prepare the tooth and cut the. I see that the teeth almost are healthy, almost are untouched, almost not completely. But full coverage is too much for them. They could use a Maryland bridge, something like Maryland bridges, resin bonded bridges.
Yes, doctor, it's not a bad option, but definitely as a prosthodontist, I would not recommend to do Maryland bridge in the posterior sides because if you look at the first molar from an occlusal standpoint, there will be a lot of occlusal forces on the molar. So the cantilever prosthetics can be on a very high risk of fracturing the adjacent teeth. So that's why probably, to be honest, on a safe side, maybe they did a 3-unit bridge because they saw the 3.5 and 3.7 has some amount of composite style restoration. So there is some degree of treatment has been done in the past. You know what? These are not virgin teeth. Maybe a bridge can resolve the solution. I understand from respectfully, I agree with them doing the bridge as an option. But my biggest concern is this implant will continue losing bone because I guarantee you there will be some communication from the soft tissue into the implant platform. There's no completely closure of the soft tissue has happened. There will be some degree of opening there.
Now another question about removing the broken screws. Sometimes they don't come out. It seems that they are attached or cold welded to the implant. Do you remove them with burr?
Today, you're only going to see 50, 70 slides of a presentation. Complications, my lecture is a full day program. When I come to Tehran, then I'll definitely show you my whole spectrum of cases. So,
or another webinar.
I do take out broken screws, and as Leon mentioned, I do take them out, but I do my best not to damage the walls. I'm actually in the process of writing an article right now on implant threading and tapping of implants after damage happened to the screws. So that's coming up as one of my future articles. Yes, we drill them out, but you have to be very careful. You are working from a 1.2 millimeters diameter, which I'm going to show you actually as we keep on making progress in presentation. I know you're very excited with questions. I get it. But let me continue with the slides, and you will see those answers in the upcoming slides. So this is what I was talking about. Look at this patient. In the previous slide, you saw the bone loss is only up to the first thread, but probably this is only year 1. Now look at this patient. Patient came from an Eastern European country. She's complaining there is discharge from both sides because under the bridge work. So when I took the radiographs, all I see is 2 units cantilever. So we talked about cantilever before. We're seeing cantilever prosthesis here. Bicuspid single molar, it's okay. I can sleep with these things. But look at this. Both the implants have broken screws. Both the implants have bone loss. Now, could have then removed these implants. Now, keep in mind, implant removal is not a very complex procedure anymore. We have fantastic kits for implant removal, but not attempting those things, doing this kind of prosthetic management with young patients is a huge, big no-no. So in this patient as well, I wouldn't have approached like this. Now, look at the amount of defect what you have on the left side of the screen. Now, we're not only looking at a vertical defect, we also have a major horizontal defect, and patient is really not happy how things are. So definitely this is not the approach what we want to follow. Prosthetic screw breaking, fracturing can happen, but if those kind of situations where we cannot salvage, we don't leave implants behind like this. We take them out and provide with new implants as a treatment of choice, not just doing secondary prosthetic planning, like doing this kind of cantilever bridge work and providing some very short-term solutions for the patient. Okay. Another case, patient had a single tissue level implant in aesthetic zone. You can see the implant. And again, now we're talking about this implant here. Patient lost an implant, lost the tooth, which is tooth number 1, 2. You can see here, and then implant displaced. Now, what do you see here? You see a tissue level implant in one side and a bone level implant on the other side, right? Sorry, the 2-1 and 2-2 sides.
The lack of the precise impression taking on the left side, and with the thought that the implant, when they screw without taking confirmation of a bite wing and thinking that the implant sits, causes a failed basically prosthesis, because the prosthesis is not sitting all the way. And it's very common in those because they go by feeling instead of by machinery like X-ray and all that to see that it's actually sitting.
So when I asked the patient told me that the doctor spent so much time adjusting my bite. I said, okay, was any radiograph taken? Oh, I don't know. They were adjusting my bite for a very long time on the first implant. Then I realized when I look at the radiograph, when surgery has been done for a second implant, I was very shocked to see that how they completely ignored that the first implant crown is not completely seated in the implant. So this is a time bomb in waiting. This can break. So I would say this is called tunnel vision. You're only looking at the problem. Prosthodontics is all about comprehensive assessment. You cannot look at one tooth and do quadrant dentistry. Our biggest part of prosthodontic training is comprehensive assessment. See how things are in adjacent teeth. See what problems can create down the road. So unfortunately, in this case, the attention was not paid for the implant restorations on the 2-1 side. You can see it's almost barely sitting on the restoration. This is not even seated all the way down.
Just the knockdown button, basically.
Other case, 2 tissue level implants. So implants are placed. I got a phone call from the implant rep. He said, Dr. Beg, my restoring dentist is having major issues trying to restore this implant. I said, you know what? Send me a radiograph. I want to see what's going on. I looked at the radiograph. I said, okay, 2 teeth are missing, 2 tissue levels implants are placed, 2 standard abutments are placed on these implants. Look like Straumann implant tissue level. I said, what's the problem here? Number 1, technically, this is where the original tooth was supposed to be. And this is where the molar was supposed to be. Okay. So I like to incorporate my planning based on where the original teeth are supposed to be and where the existing implants are. So this is what they're trying to make a restoration on this case. Now, biggest challenge is here. You see the green circle? You cannot seat 2 impression copings at the same time. If you look at the tissue level impression copings, they are so big and bulky that they cannot line up them together, because from a surgical standpoint, they place the implant is placed, they take the implant mount off. Then they start placing the second implant. The first mount is a guide for the second implant placement. You place the first implant, take the mount out, you're freehanding the second implant, you think you're doing a fantastic job, but when you come back to the prosthetic planning, this is what's the problem. Now, look at this patient. Has an implant placed, angled more mesially tilted. You can see the little balloon in the sinus. That means there's a sinus augmentation done on this case. Now, just imagine talking to this patient saying that, oh, unfortunately, the distal implant is not right. When you take it out and do a new implant, when the patient is going to say, I already spent so much money on sinus augmentation and implant placement. Why should you take this implant out? Now, I don't know how things work in Iran, guys. In Canada, there's something called big liability, and we don't want to run into these issues, because if things go south, we will have a major issue with the licensing bodies that we might end up having some effect on our license. So implant planning and execution is a very big part of education, and especially in Canada and USA.
In those type of cases, it's like usually when they refer it to Dr. Beg or the surgeon refers it to Dr. Beg, the GPs are not capable of doing it because they try doing it the first time and it doesn't work. And the situation with taking the x-rays and all that, I mean, in that case, it would be ideal to restore one implant and then take a custom impression coping to the other one. So you will be able to do a tighter contact, because even when you pull the impression for those, the 2 impression coping, when they come out, they might move and shift. So you're not going to have a very good fit after.
We had something like this. The implants were like this. And we managed, of course, it was very difficult. We managed to take impression from the mouth. But I thought perhaps we could do it digitally. First with a scan body on one of the implants, scanning, and then on the other implant and scanning and merging these together. But I'm not sure it would be quite accurate. I have never done something like that.
For contact purpose, it would not be accurate. That's why it's better to do one, finalize it, and then do the other one. And it's better to do the one with a better kind of like, to achieve a better contact. And we cannot really split those because they're on different levels, you know. So it would be better for a contact to do it one at a time.
So I have done cases like that, Leon,
I'm sure
as
you
Dr.
do.
Farid mentioned. So don't worry, I saved all the good stuff when I come and see you guys there.
Thank you.
Okay, so let's continue. Look at this patient. Patient was referred to me, oh, Dr. Beg, patient constantly complaining of broken screw. I said, okay. Loosening of the implant crown. So every time I tightening up, things are loosening up. And I went back, I tightened them again, and then they come loose. Guess what? One day, everything broke, and now I cannot salvage this. I'm leaving this as is. Can you please take care of this? So when I saw this patient radiographically, I'm looking at this case. A molar is missing, second molar. Okay, and what else do I see here? I see an implant there, and I also see on the radiograph a root remain. So if somebody is really planning so hard for placing a single implant there, if you're really that good of a surgeon, I hope you made an effort to remove that broken fragment of the tooth as well. And what they did is they were so lazy to remove the broken fragment of the tooth, they placed implants more distally. So you know what? I have a space, I'll place the implant. But prosthodontics was not part of the planning. Look at what happened. I took out the broken screw and I told the surgeon and the restoring dentist, I'm not going to be able to place the implant, but the crown, but I'll displace the crown from a photograph. So this is what I removed, the broken piece of the screw. Okay. Now look at the crown and look at how this crown is now. Mesial cantilever. Okay. All the occlusal forces are on the anterior part of the tooth. The most important thing is you want to direct occlusal forces on the long axis of the implant restoration. Now, molar mesodistally and implant mesodistally doesn't match it up at all. That's why you cannot have an implant almost size of a molar. Now, that is why you wanted to place the implant in the most strategic place so that occlusal forces are on the long axis of the implant restoration so that you're not going to have a screw loosening problem. Now, I was able to salvage, take out the broken screw, but look at this case. If you go back and place a new screw again and put back this crown again, you think this is going to last again? Probably not. I told the surgeon, the referring doctor, there's a chance that you might have to remove this implant, remove the root fragment, graft the site, bring the patient back, place a new implant, and then do the restoration. He said, you know what, I think that's the best approach to do, because if not, every 6 months, you're going to having this situation, you're going to be sending it to me. And in the next 1 year, you're spending so much money with me that you could have done a new implant for this case with the complication management. Sometimes it's not worth to repair the old car, you better buy the new one and move forward.
Remove the implant, clean this area and put another straight implant. Yeah.
Okay, I don't know how much time we have, doctor. Is already close to the time.
It's okay. It's okay. It's very interesting, and I hope you continue. Continue, please. We take the break time.
Okay, deep break time.
Okay.
Continue.
So, majority of prosthetic complications are not. This is a very important statement, guys. I know there are 40 people in the audience. I want you to read this very carefully. Majority of prosthetic complications are not related to the choice of implant. A lot of times we blame the implant. Oh, implant was not good. Oh, implant did this. Okay. While complications can seldom be related to the implant component design, they are most often related to the manner in which implants are positioned and utilized. So it's not the car which is the issue, it's the driver who's driving the car. So basically, most of the implants are FDA approved. They have a fantastic, robust designs they have. Yeah. But the problem a lot of times, what I have seen is, I am not saying all the implant companies are great. I see a lot of times there is defects and flaws in the implant system, which I readily communicate with the implant companies. I'm very vocal with them. I said, you might be a multi-billion-dollar company, but this is the flaw in your system. You need to look into this from a scientific standpoint, talk to your guys, see what they think. But most of the time, what I see is planning is very poor, execution is very bad. Not a lot of thought process goes into the whole process of planning. And that's why we run into a lot of issues. Okay. That is why if you look at all these previous cases, the biggest challenges where I've seen is a lot of times surgical guides are not being used. Surgical guide is a fantastic tool. It helps you really understand how the implant has to be placed, apicocoronally, mesodistal positioning, labioparallel positioning, and also it provides some great information to the surgeon where exactly the gingival margins are supposed to be, angulation of the implants. if there are any embrasure space has to be respected. You're not really closing it too close because there is enough data to support that you have to maintain very specific amount of inter-implant distance. That's what we're going to talk about now. Okay, buccolingually, mesodistally, implant surgical guides are a great help. I hope in your university you guys are following this protocol, providing guides to a surgeon prior to the surgical implant placement. Yeah, single implant, I understand, I get it. But if you're missing more than one tooth, definitely provide surgical guides for your surgeon so that you get a better outcome with your surgery. Now, a lot of times when surgical guides are utilized, but sometimes due to the limitation of the bone, we definitely run into issues where that implant angulations can be an issue. For example, here in this case, implants are placed, but the emergence of the implants is almost having on a buccal axis. Like obviously in aesthetic zone restorations, you want to temporize and the big help. And I wouldn't recommend you to do a cemented temporary. I would highly recommend do a screw retained temporary because you can control how you're going to optimize the soft tissues. Yes, you have a situation, you have a buccal axis, but we have so much options right now. Angle correction prosthetics can be used. You can minimize the angle correction till almost up to 30 to 35 degrees angle corrections can be done. And you can change this incisal buccal axis into a single axis and not have to make a cement retained crown. You can definitely follow the protocol of doing a cement screw retained crown. But some cases get very challenging. I'm going to actually show you one or two cases. Now, as I discussed before, intraocclusal space is very critical. You want to have that amount of space for prosthetic rehabilitation. And especially if Leon want to comment something on why it's very critical and what challenges you face as a lab person to manage when you don't have enough intraocclusal space with your prosthetic heights.
So basically by the lack of planning of the intraocclusal space for the final prosthesis, what does it cause? It causes the inadequate material thickness, which means even if we're going to restore it with metal ceramic, we'll have to cast something very small with UCLA, gold adapt, and put ceramic on top of it. Now, if the material is not equal thickness all around, it starts chipping. In metal ceramic, in zirconia, it will start breaking in the middle through the small vario base. If we're going to just do a full gold, like you see, that's what they restored on the last implant at the right side picture. That's why, because they did not have enough room, all the other materials would break. So even though that, yes, we are function driven and we want to have first functionality and gold or silver crowns is good, but in the end of the day, the lack of room, that's why they've done the gold, and the crown beside that, they've done a zirconia crown. And the one beside that, it's a natural PFM. It's all about, and you can see that probably those patients have very heavy bruxism, like they have a very heavy bite. And that's why when restoring those, sometimes on those cases, even for single implants, would be a very good idea to trim a little bit the bone, to put the implant a little bit deeper, so we can have a little bit taller prosthesis in the end.
So we have to really respect the fact that taking into consideration, these are actually very classic articles done by Torno, and I'm sure in the department you guys have read them so many times, why we have to maintain 3 millimeters of the CG of the adjacent teeth, the implant restoring platform, especially when you're talking the depth of the implant, inter-implant distance, minimum 1.5 millimeters between the adjacent teeth and the implant restorations. And this is, we're talking about the implant peripheral diameter, not from the implant center of the implant. It's on the peripheral diameter is 1.5 millimeter. A lot of times we might be thinking, oh, we're going to place a 3.3 and we're in close proximity. No, it has to be from the outer diameter of the implant is what the measurement is really taken. From the prosthetic platform, not from the apex of the implant. So these are very, very important measurements what you have to follow. Now, sometimes implants get placed deeper. We try to make temporary so that we can create an emergence profile for the patients. And again, we want to see how we're going to optimize the soft tissues, create the ideal emergence so that we can have a long-term restoration. So implant ideal placement, implant temporization, implant interim prosthetic fixed temporary is a very critical part of the planning, especially when you're doing aesthetic zone implant restoration.
Yeah, I agree. Contouring the soft tissue by a temporary, it's one of the most important things there is, because it's not only from the perspective of the functionality, it's the color aesthetic. So if you do not have the supportive tissue, the crown would always look gray around it. It's due to the metamerism of light and the way the light hits the tissue and the crown together. So that's why we always recommend doing the temporary crown, just so we can not only get the nice contour of tissue, so that when I restore my final crown, I will be able to be on the same platform with the teeth. So the light reflection of that tooth central teeth, which is, everyone knows, single central is one of the hardest things to do. So by doing the temporary, we basically try to remove another complication with the color after.
Yeah, it would in one of the cases that you have the problem with interproximal tissue, I think a soft tissue grafting could be solution, could be an option. And sometimes in cases that we don't have enough interproximal dental papilla, we can use soft tissue grafting. Have you ever used it? Have you ever asked your surgeon to do this for you?
Yes. So we have done cases where we do the soft tissue augmentation, the connective tissue graft. Yes. That's why in the beginning I mentioned that we're not going to talk about biological complications. Kept it very specific to prosthetic end. And that's also is a standalone presentation on its own, how we manage with a combination of enhanced grafting procedures for better aesthetic outcome, not only relying on prostheses for the patient's aesthetic management here. So,
I mean that when you are planning your prosthesis, have you ever asked your surgeon to do this for you?
yeah. So when I communicate when I have a patient, like for example, this patient, I saw him before the surgery was done. I did clearly mention to the patient that with all my aesthetic cases, I always tell them there's almost 50% chance that we might end up doing some kind of soft tissue augmentation if you feel the amount of keratinized tissue is not ideal what we're looking for. So definitely it's part of the conversation with the implant planning. Yes, especially in the aesthetic zone, I definitely incorporate that as a communication with the patient. Yes.
Thank you.
Thank you. No problem. So again, you can see here, these are also from a Boozer's article, how he's trying to differentiate between a green zone, which is a comfort zone, and the red zone is a danger zone, mesodistally or buccolingual, apicocoronally. That's the reason we need to really follow the protocol so that we're not going to make any kind of compromise placing the implants in the off-axis position. Now, we talked about proper positioning, then suddenly we end up having a case like this. So this is the patient. Very young patient. You can see beautiful central incisors, nicely lined up. He's an avid player of ice hockey. So he was not wearing his helmet that day. The puck came, hits right into his front mouth. Both the teeth got fractured. And then these two teeth were extracted and implants were placed. And now that's the problem. People see me after everything is done. I wish I get involved when the puck hit his mouth. So at least I know that I can be involved in this case. This is how the patient came in. Okay. Teeth were extracted, 2 implants were placed. And I was told, oh, we tried to restore this case, Dr. Beg. Unfortunately, we could not. Can you please do something and get an ideal result in this case? Now, if you look at this patient right now, what was the most ideal inter-implant distances? 3 millimeters. I don't think I can see 3 millimeters between these 2 implants. All I can see is a millimeter of space. So now, a very young patient, huh?
Between the healing cups.
Between the healing cups.
Not between the implants,
Yeah.
between the healing cups.
So I said, you know what, let me analyze this case much further detail. So buccal frontal view, look at the canine position, 2 implants already replacing 2 anterior teeth. And I asked the patient to close in maximum intercuspation. Now look at the maximum intercuspation, deep bite, superrupted canine, 2 closely placed implants. So you name it, all the problems, what you need as a prosthodontist have lined up in this case. Now, who's going to sign up for a case like this? So it's going to be hard to manage this case. So I said, you know what? No. We need to take 2 steps backward in this case. Let's analyze this case. Patient is only 32-year-old young guy. You will see his picture when I show you the final restoration and how we manage this case. Okay. I said, you know what? Step 1, let's make some temporaries to see how ugly they are, how we can manage this case, how much amount of soft tissue grafting might be done. Now, soft tissue grafting is an option in this case, doc, but how would you create interproximal papillae between 2 implants, which has less than a millimeter of space? So coming back to your question again from a previous slides, why don't we submerge one implant, use only one implant, and able to do a restoration? Now, anybody in this audience can take a risk when you already see a patient with 100% deep bite, single implant, huge anterior guidance, all are red flags in this case. So we really looked into this. I said, you know what? Step one is, let me start this case with orthodontics. Let me fix the bite correctly, properly first. Now, keep in mind, in this case, I asked the surgeon only to line up all the lower anterior teeth and the canine in the upper right side. So from an orthodontic perspective, the patient had brackets and different, and again, we use implants as an anchorage also for doing the intrusion process. So implants are amazing tools for using as orthodontic anchorage. In this case, I made temporaries, we use them as an anchorage. You can see the bonded brackets on the implant restorations. We tried to do our best to manage this case. We already know the answer. Interproximal tissues is missing. Either we have to do some soft tissue grafting, which is going to be very unpredictable in this case. So we want to do some kind of pink porcelain. Okay. So you can see from his picture, he's not a 70-year-old man. He's a very young guy. This is his case with the smile, with orthodontic treatment. Orthodontic treatment really helped to establish the incisal line. Patient has a low smile line. So we're able to say, you know what, even if we do soft tissue grafting, I don't know how much outcome we can have, because my biggest fear was what happens if I lose any bone around this existing implant. So we did not take any risk, and the surgeon did not take a risk as well. So you can see here how we have aligned the lower anterior teeth, and also we have alignment of the canine as well. And again, once the orthodontics is done, this is just to show you the before extraction, implant placed, and now after the orthodontic treatment, everything is completed. And the final restoration was to make a veneer on tooth number 2-1, a single crown on the 2-2, and gold base abutments, both of them with a 2-unit with a pink porcelain.
Yep. So in this case, we decided to restore the whole 4 teeth because his presentable teeth did not like them as well. So okay, let's do all 4 of them.
The symmetry, yeah.
And the symmetry, the reason why did we ended up going again cemented, because the deficiency in the tissue instead of doing screw retain. Probably now in 2021 and 2022, I would definitely do it screw retain with the abutments that Straumann have came out with, probably angled solution Straumann Variobase, the angled solution ones. But back then they did not have them that popular, and I didn't want to take a risk for a guy that has such a heavy bite, put him a small tie bases. The problem is when I choose my restorative abutment, and sometimes how am I doing it? Those 2 crowns, I think, still was screw retained. We opened the holes at the back, right?
Yes.
Yeah. So this is just a picture. I cemented them after, and then Dr. Beck screwed them in. Now the problem is I could use the small variable bases but then from the bite, as much as you remember, because it was so deep, relying on a very small tie base, I'm basically taking a chance from them debonding and fracturing.
But the result was incredible.
Sorry?
The result is amazing.
The result is amazing.
Comparing the beginning,
he was very happy. He was very happy.
It's very nice, really nice. Nice job.
The day of the insertion. This is at the day of the insertion. I think after 2 weeks, he came back for 2-3 weeks. He came back for some more pictures. So the tissue nicely hugged the polished ceramic. At the tissue, when I do it, I always polish my ceramic, no glaze. So the tissue doesn't have the abrasion from the ceramic particles, you know. So when you polish it, it's like a glass.
And look at this guy. Look at his smile. I can't even say that he has implant restoration. We used what he got, fine-tuned a little bit with the prosthodontic management, made the case completely multidisciplinary, got his way line up to be, and then we did very simple, non-invasive prosthodontic treatment and able to get a very ideal result. And overall, patient was very happy.
Yeah.
Wait.
That was wonderful, and thank you so much. And this lecture was really very informative, very well designed, and I hope we can have you again and again later.
Soon enough. Now they open all the doors. We would love to travel and come and me and Dr. Beg are planning to put a small course over here with actual live patients course where we can approach with some veneers and crowns and maybe even an implant. So, you know, those dentists who don't feel very comfortable with how to approach those cases, what to do first, what to cement first, why to cement first the veneer and then place the implant crown. It's like there is basically steps to all of those. We basically worked on a very good protocol following ABCD, so we will be able to get those results in the end.
Yeah, and where is your, do you have a program for it, Dr. Beg?
Yeah, so yeah, it's coming. Actually, I'm part of we actually coming up with a Digital Excellence Center in University of Rochester. I'm part of the planning committee there. And also I wanted to have the same thing incorporate in the Toronto as well in Canada for providing the most advanced digital technology care. So definitely, Doc, I'll keep you in the loop. I'll keep you informed. And my apologies, everybody, audience. I'm so sorry we went a little bit over time because again, if you have any questions, Dr. Farid has my email. It's very simple, bobbybeg@gmail.com. If you have any cases, any questions, feel free to send me a message. I really thank you all for being very patient with me. It's almost like 2 o'clock in the night right now.
So sorry for closing the eyes and blinking so many times.
Thank you so much for being with us and supporting us and for presenting such an incredible presentation. And I hope we see you again soon.
Thank you so much.
Yes, thank you.
Have
everybody.
a wonderful
Have
day.
a wonderful day. Okay.
Thank you. Ciao. Bye.
So bye to now.
Bye.
And our next presenter is Dr. Ehsan Morshidi from Tehran University of Medical Sciences, School of Dentistry, Prosthodontic departments. Dr. Morshidi, first of all, I should apologize for being late and your presentation is beginning not as time it was scheduled. I'm so sorry, but the Dr. Beg's presentation was very interesting. So now, please, you can start your presentation.
First of all, I have to say hello to everybody, especially Dr. Beg and Dr. Farid, and also Mr. Google. And have to say special thanks to Dr. Beg for his special outstanding presentation on digital dentistry, digital implant insertion, and also space management. It was absolutely useful for me, especially in my special cases, my personal treatment cases, and this shows us how we should concern about our patients, especially in space management. Implant treatment is not also it is not only inserting the implant. The final thing the patient asks us is the final treatment. The patient asks us is the prosthesis. He or she needs the prosthesis, not the fixture in the bone. And this shows the ability and the skill of a prosthodontist. I have to say thank you very much, Dr. Beg. That was very useful for me, especially for me, and absolutely it was for others as well. And I ask you and invite you to have your great lectures in our next tours, especially among your lecture about complication treatments and managements, especially about broken screws. That was very interesting for me to see how you manage the cases of broken screws. This is the big problem nowadays. We face it, and most of the cases after years are coming back to us with the cases of the fractured, whether the fixture or whether the abutment or the abutment screw as well. If you let me, I will start my presentation about digital implant workflow. This image you see is the image of Tehran, the city where I was born. I grew up and I started my education in dentistry, School of Tehran University of Medical Sciences. And this is the main entrance of Tehran University of Medical Sciences. Actually, it is the entrance of the medical school. The entrance of pharmacy and dental school are located at left and the right side of this entrance. Okay. Today I will speak about what digital implant workflow is in a very, very in a very simple way, which will be more useful, especially for dental students and who are looking for newer technologies in dental implants and treatments. That may be useful for Dr. Beg as well. The main aim and the main goal of digital implant treatment is to locate the implant in its proper way. We have to know the diameter, length, and depth, and direction and orientation of the implant, and where it has to be placed exactly before any surgical process. And the other main goal of the digital implant treatment is to manage the soft tissue as well, and also save chair time. These are the main goals of the digital implant treatments. Look at this case. This is one of the cases that is not digitally inserted. It is inserted freehand, and not also the lack of skill shows itself in this case, but also the lack of plan, where to place and where to insert the implant is obviously seen in this case. What did I do with this case to manage it? I couldn't screw two impression coatings close to each other at the same time, so I had to separate one of the impression coatings into two pieces and screw one of them in its place, and screw one of them in its place, and fix the other one to the prior impression coating and make my impression, and also fix the fixture analogs from the other side of the impression to each other. And I treated this case just like a single molar with two roots, but the complications in this case are still remaining. The lack of proximal soft tissue, which causes a lot of food impaction in the proximal area, and also the lack of ability of the patient to clean the interproximal space of the two implants close to each other. This is one of the cases that I have not completed it yet. I'm working on it still, and I hope to get a good result from the treatment. Look at the other case. Look at this case. Placing the implant very, very bad in bad angulation, very bad direction, very bad position. And look at the impression coating screwed in its place. I couldn't treat this patient, and I referred it to another surgeon to explant the fixture and also manage the site with GBR and GTR, and again, after a while, place a newer implant. These cases all shows us that treating the patient with implant needs to plan everything before insertion of the fixture. Nowadays, the implant treatments are not surgical driven anymore. They are prosthetic driven anymore, which means we have to design our prosthesis first and start to design a good prosthesis which will function in the patient's mouth. And after a while, after that, try to locate the fixture in the proper position beneath that designed prosthesis. So let me see what are the benefits of the digital implant treatments. One of the most important benefits is to design where and how should the implant inserted. The other benefit is time saving. You can save a lot of chair time because the number of the sessions you visit the patient are reduced, and so you can visit more patients in this save time. As you can see, in the normal conventional way to treat a patient with implant, we have at least 7 to 8 visits from CT scan, ordering to surgery, stitch outs, and step 2 surgery, impression making, temporary crown delivery, and final crown delivery. It takes a lot of time, a lot of chair time, and in digital process, it takes less, at least almost 3 to 4 sessions. It takes from intraoral scanning and Cbct ordering to second session, which is surgical process and delivery of the provisional crown, and final crown delivery at the third session. So what are the other benefits in digital implant placement? One of the other benefits is that because we usually, not always, but usually do the digital implant surgeries flapless, so we can have less bleeding in patient's mouth, so it brings more comfort for the patient, and the patient anxiety may be reduced. The other option that digital implant placement gives to the patient is minimum operation time. When you try to reflect the flap, and after placing the implant to suturing the flap, this takes a lot of time. A good closure takes a lot of time, and this reduces your time. And finally, the other important benefit of digital implant placement is to saving surrounding structures such as adjacent tooth and anatomic structures, just like floor of the sinus and also intraoral channel. In this slide, we can completely see how the digital workflow goes. In the first step, we have to take one single image of the superficial structures of the patient's mouth, which is called intraoral scanning. It is taken with intraoral scanners, and it's just a very, very precise digital impression, and also a digital cast of the patient, which shows us all superficial structures, such as the remaining teeth and also the surrounding and superficial soft tissue. The other image that we need for this process is the Cbct scan. The Cbct scan gives us also the hard tissue, such as the bone and the remaining teeth, and also the important structures such as sinus and inferior canal in mandible. The common part in these two images, the common part in Cbct and intraoral scan, is the remaining teeth. So we need software here to merge these two images from this common part. The softwares are very, very progress these days. One of them is Implant Studio, which I usually use it. I can use these two images that I taken from the patient mouth, one of them intraoral scan and the other one Cbct, from the common part, which is the remaining tooth, onto each other. So in one single image, I can have all the parts I have in the patient oral cavity, such as the remaining teeth and the superficial soft tissue, and beneath of that the supporting alveolar bone, and also the anatomic structures such as sinus and inferior mental foramen, and so on. So I have everything in the virtual environment to do my virtual surgery several times and do mistakes several times to achieve the best position for implant placement and the best position where the restoration of crown must be located. In this process, we do everything crown to implant. It is called prosthetic-driven treatment. First of all, we design the prosthesis in the proper position that it should be, and then after that, we place the implant beneath that prosthesis, and because we have the superficial soft tissue and we have the superficial surface of the bone, we can calculate easily every single place of the gingival thickness. So we can calculate the gingival height of our temporary or final customized abutments. This gives us the ability to prepare the patient's final abutments with its proper anatomic gingival heights and produce its temporary crown. After we design the position of the implant, the position of the restoration, and also the abutment, we can produce a surgical guide, which is usually in simple cases which are tooth-borne or partially edentulous. We can design a surgical guide which is located on the remaining tooth, which is called tooth-borne surgical guides. These guides are very stable because they lean back on the remaining teeth, which are hard, stable tissues, which prevents any single movement, and it is very stable during our surgery. These guides include some sleeves with special angulations, which we designed the angulation of them, and these sleeves guide our drills in which direction to drill the holes for inserting the implants. There are different types of intraoral scanners in commercial, available in commercial. One of them that I use it's Trios 3 shape, which I really love it. After scanning, you can see you can merging the image of intraoral scan with Cbct image, and also planning the tooth structure, the crown structure, and place the implant beneath that, and also print the surgical guide. This is the process in view. You can see the intraoral scan at the left top, and the surgical guide, which is designed on the remaining teeth in the middle, and the abutment and the place of the implant at the right top, and the temporary restoration or even the final restoration here, and the final restoration, which is delivered to the patient. In the how to produce the surgical guides. Nowadays, we design our guides fully digital, but prior to this, we designed them in two other ways, which were at the left side, we can see fully analog. At the middle, we can see partially analog, partially digital, or half digital. And at the right side, you can see how we produce how fit and how precise are the fully digital produced surgical guides. In the left image, you can see we have the stone cast with power orthodontic resins or PMMA powder and liquid on it, and we produced surgical guides which were not very fit to the patient mouth. At the middle, we as we have plaster cast as well, but we do some digital impressions with in-lab scanners and print our surgical guides via 3D printers in lab process. But, so this process is half digital because we have both plaster casts, which are analog, and we have printed surgical guides, which are digitally produced. And at the right side, we can see the fine fit of the surgical guide on the patient's teeth, remaining teeth, which is fully digital, which means we have digital cast, which is the result of our intraoral scan, and the printed surgical guide, which is the result of our designing in our software. You can see the that fitness of the fully analog type of our surgical guides here, and half digital here, and fully digital here. Okay, let's go ahead. In such cases, after scanning oral structures, we merge two images on each other, and we place the final restoration or temporary restoration and design the final restoration on the remaining edentulous side, and design the place and direction, and plan how and where and in which direction position the fixture should insert it. You can see it in the bottom of the picture. And after designing the restoration and the placement, the place of the fixture beneath the restoration, we can also design our surgical guide, which has sleeves that guides our drills into the proper position to place the implant, which we designed to be. And this is the surgical guide. We designed it. It had a metal sleeve in it, and this sleeve guides special the drills in very specific direction and position. What material can we order to the lab to produce for us for a digital implant process? We can order our final customized abutment, the temporary restoration, and also a transferring jig, which is used to transfer the abutment into the proper position in patient's mouth, and also the surgical guide, which is in this case, which is completely tube supported. Also, we can order a drill sequence for the patient, which helps us to choose the drills in the proper manner and do not miss any drill anyway. It's easy. It's really easy to do the implants in this way. And crown setting, how to deliver the crown to the patient. After placing the implant in its proper position, we can deliver the abutment in its true position, which a transferring jig, which leans back to the adjacent teeth, and we can screw the abutment in its proper position, and after that we can place the temporary restoration in its proper place. And here we can see the restoration in its place and total. Thank you very much for your attention. Thank you, Dr. Farid, for your invitation to this beautiful course. Any questions? I'm at your service.
Thank you so much, Dr. Morshidi. Thank you for accepting our invitation, and we are so happy to have you with us here. I'm sure everybody has enjoyed your presentation. Again, excuse me for the delay, and I don't see any question in the chat box, and I think because we have our next presenter, Dr. Al-Hassini, at 11 o'clock to have a 15 minutes breaks for everybody. Thank you so much, Dr. Morshidi.
You're welcome. Thank you. Thank you.
Dear audiences, thank you for staying with us all from the 9 o'clock to now, and enjoyed the presentation of Dr. Bobby Baig and Dr. Ehsan Morshedi. We will be back at 11 o'clock with Dr. Ahmad Al-Hassini. So see you then.
My pleasure. Thank you for having me.
I introduce you to our colleagues and audiences. I asked one of my colleagues to have a lecture for us, and he said that I won't, but I introduced to institute that they will help you, and you did help us, really help us. Dr. Al-Hassini is director of Institute of Digital Dentistry in New Zealand, Wellington, New Zealand. And when I asked him, he accepted to have a lecture for us. And this is very kind of you. Thank you so much. It is our honor to have you with us. I have seen a lot of your publications, a lot of articles, and that's very amazing. I'm sure all our audiences will enjoy your lecture. The topic is Intra-Oral Scanners review. Which scanner is the best in this market? So Dr. Al-Hassini, if you want to talk a little bit for us, we have 2 minutes for the starting your presentation. Do you want to say anything?
It's just an honor here to be here, and I appreciate the university inviting me. Of course, I'm very passionate about digital dentistry, as a few of you may know, and I love any opportunity to connect with colleagues around the world and you know, just share all the information that's out there and make it a bit easier for those to get into digital dentistry. I do have a question. Is it mainly students or postgraduates or faculty that are joining us today?
All of them, almost all of them. A general dentist, specialists, and students.
Oh, nice. Well, I congratulate all the students for sure, because I assume they're dental students. You're going to enter an amazing industry, and an industry that's changing very rapidly, you know. And I graduated not long ago, about 8 years ago, and it's something that's even within 8 years has changed completely. So a big congratulations to all of you. I guess I can start sharing my screen because I have a few slides anyway, just about me, and then we can get into the presentation.
Okay.
Can you all see that?
Yeah, we can.
Okay. So, I mean, I guess I can make a start and I'll introduce myself. Today's topic really is everything about intraoral scanners and just making sense of the entire intraoral scanner market. As Farad mentioned, I'm the director of the Institute of Digital Dentistry. My name is Dr. Ahmed, and I'm a full-time practicing dentist. I'm one of these crazy guys who also works weekends for some reason. In New Zealand, our days off are Saturday and Sunday, and I just finished clinic actually. Had a busy day using a lot of digital dentistry equipment, but the focus really is to go over the entire market, and that's what we'll be doing today. So a little bit about me, guys. Some of you may have seen a lot of my posts online or in Facebook groups, or if you've done a Google search. I come from Iraq, so a neighbor, and my father and our family left Iraq in 1992, and we immigrated to a small country in the corner of the world, New Zealand, very far away. So I graduated from the University of Otago here in New Zealand. It is the only dental school in New Zealand. And now I work alongside my father, who you can see in the middle there, and my brother, and we're all dentists. So we all work together, which is really nice. And my father is a very passionate dentist. He was the one who actually got into digital dentistry. I was very fortunate to have a job with him and be able to work alongside him. So in our practice, we are early adopters of CAD/CAM dentistry. This is a picture of our in-house dental lab. And we got into CAD/CAM over 15 years ago. That was my father. He bought one of the first scanners in the country. And nowadays, it's a key part of everything we do. I mean, today I just finished my normal 9 to 6 working day, and I use scanners in at least half of the patients, whether it was for orthodontic scanning, same-day crowns, implant scanning for aligners. It's part of everything we do now. And because of our position, we were very fortunate in that we owned and we privately purchased a lot of scanners. This led to the Institute of Digital Dentistry, and IDD was really just a passion project because I love dentistry and I'm very passionate about digital dentistry, and I just wanted to share information with everyone. Now, when you're getting into scanning, you will face, a lot of you are still students, you will graduate, and eventually you will be business owners, or some of you may already be dentists who are considering, getting into digital dentistry and buying a scanner. Now, you will face the same questions as we faced 15 years ago. Nothing has changed. And you question yourself, you wonder, is there a good return on investment? Is it hard to learn? Is it worth the cost? Is it accurate? And you also wonder, why change? Why change what's working now? Impressions technically work. But over the years, what we learned is all the advantages of digital dentistry. And I'll touch on those briefly, but today really I wanted to go over the scanners themselves. So when we first got into CAD/CAM and digital dentistry, I mean, these were your two options. This was 15 years ago. This was an old E4D scanner and an old Cerec scanner. This was the blue cam. And that was it. That was the two options in the entire market. Over the years, there's been tremendous development. It is a bit like Samsung or smartphones or iPhone or all these things. Every year it is changing, it is improving, to the point now where if you compare something from 10 years ago, it's a wildly different product. And that's why some dentists, when they adopted CAD/CAM or digital dentistry 10 years ago, they struggled with it because it was very hard to use and it put a bad taste in their mouth. And these days it is just much easier. It is a no-brainer anymore. So we went from these two scanners over 15 years ago, and now we have this many. And this is not even the entire market. This is just some of the scanners that I personally test and I use. And it can be very hard to decide, how do you choose here? Because every sales rep will tell you their scanner is the best. And that's what we're going to touch on today. Now, before we get into scanning, you also have to ask yourself, why intraoral scanners? I mean, why do we want to do it? There's got to be a reason to change. There's got to be a reason to invest. And I'll only put one slide here, guys, for you, because I think these days everyone understands the benefits. 10 years ago, we used to educate and do courses and people didn't really understand why CAD/CAM. They thought it was a bit of a hype topic, it didn't really seem like the go-to. But now it's just well established. Look, dentistry is going through a transition, just like we transitioned from film x-rays to digital x-rays, just like we transitioned from amalgam silver fillings to white fillings. Dentistry is undergoing a transition now. And I have no doubt in my mind that eventually every clinic will have a scanner eventually. It's just a no-brainer. So the benefits of scanners are endless. There's speed. For me, it takes 30 to 40 seconds to take a full arch scan. Compare that to 3 to 5 minutes of a PVS or silicone impression. The comfort, there's no gagging. Even for young children, it's comfortable. Patient education, you can engage the patient, which is very important these days, because in dentistry, it's not just about telling a patient, oh, you have this issue. You actually have to engage them in their own health. The wow factor, and they're easy to modify and store these files. I think we've all been there, I don't think anyone enjoys taking impressions. I personally don't. And funny, when I was going through dental school, I was actually traumatized because the first impression I took, the patient was a severe gagger, and I was very scared of taking impressions from then on. So, there is a better way and there is a much easier way. Obviously, also with scanners these days, there is a lot of features in them, like caries detection. A scanner now is not just an impression tool. It is also a communication and can be a diagnostic tool. Some of my favorite features are things like smile design, and these are factors incorporated in the scanner software. And this is, you can see it, you know, if you show a patient this is an extremely powerful communication tool in your practice. If you're interested in cosmetic dentistry, you should be using this. It's just a no-brainer. Lastly, also aligners. Aligners is a big market. A lot of people want aligners. A lot of adults prefer aligners over braces, and being able to simulate results to show patients about these sort of procedures is, again, extremely powerful in your practice. So what are the indications of a scanner? What can you use a scanner for? And in summary, it's basically everything. Everything you can use an impression for, you can use a scanner for. And there's only two exceptions. Full dentures, when the patient is edentulous, where in my office, I just take an impression and I scan the impression because I still want a functional impression. And the other exception is full arch implant restorations, where you can still use a scanner, but you would need to use photogrammetry or use some sort of verification jig. Apart from these two very niche and very complicated pieces of dentistry, the rest of dentistry can be used confidently with a scanner. You can do all sorts of dentistry with a scanner confidently. Fixed pros, crown and bridge, DSD, smile design, implants, surgical guides. These are all things I do in my practice, and I haven't taken impression since dental school, apart from removable prosthodontics. It is a product that when used correctly, it will replace impression in your practice. What about accuracy? This is a very common question that everyone who gets into scanning, you know, it's a contentious topic, because 10 years ago, no one believed they were accurate. And I believe the products of 10 years ago weren't very good. These days, I think most people appreciate that scanners are accurate. I mean, it's accepted these days. And if you don't accept it, the handy thing is the literature is there. There's a lot of literature now. 10 years ago, there was not much literature, and you just had to believe the sales rep or the guys like me who are early adopters. But these days, there's a lot of literature to show that digital impressions are as accurate as conventional impressions. Digital impression techniques are clinically acceptable alternatives to conventional impression. Okay, and current intraoral scanner technology is as accurate or even more accurate than impressions. And I'll show you more literature to discuss this. There's the obvious things as well. Like, we know personally an impression is less comfortable than a scan. I mean, that's just logic. But there's also literature to show that it's more time efficient, and patients prefer digital impressions. So it's just a matter of time till everyone adopts this technology. There's also research coming out of the United States, and these are some excellent clinicians in digital dentistry. And what these clinicians did is basically compare all these different scanners with scanning a cadaver, because obviously a scanner is an optical device. So scanning stone models is a bit different to scanning teeth and gingiva. So they showed that all these scanners are within, 30 to 50 microns of accuracy when compared to a control industrial scan of that cadaver head. So, 30 to 40, 50 maybe microns of accuracy is exceptional, because PVS is around 37 to 40 microns. And what's also quite interesting about this research is that all the scanners are roughly the same. So this discussion about one scanner being more accurate than the other is a very ancient and dated discussion. Most scanners work, and most scanners are more than accurate enough for the vast majority of indications. And that's my experience too, because I use all these scanners in my practice. I'm still a practicing dentist. And this is one example. So this is just anecdotal evidence. This is a full mouth rehab I did completely digital. And as you can see on the x-rays, I think all of us would be happy with margins like this. Maybe not the prosthodontist, maybe in the audience, but look, I'm quite happy. And this has been in the patient's mouth for over 4 years with no concerns. And this is all with scanners. So really a lot of the accuracy concerns, we need to understand that the most significant factor in causing inaccurate scans is the operator. And that's well established in the literature. If the operator doesn't train and know and understand how to use this optical device, there will be inaccuracies. You need to understand basics, you know, it's not anything special, basics of tissue management, just like impression, fluid control. But the operator is key. So look, that's enough about that. I am here to talk about scanners and scanner reviews. So let's get into that. This is your armamentarium when you get into digital dentistry. And your first step is always an intraoral scanner. This is your gateway into digital dentistry. Without an intraoral scanner, you can't do digital dentistry. And this is why it's the first piece of equipment most practices buy. As I mentioned, there's a lot of scanners. These scanners I have arranged for you by price from the left to the right. Now, I know some of these scanners are not available in Iran, like the iTera on the left. I will get to that in a second. I don't think you're missing much, but the iTera is the most expensive at around 40 to 50,000 US. And now we're getting Chinese scanners, which are around 10,000 US. So there has been a significant decline in the prices of these products. And as the price goes down, the barrier of entry goes down and more people will adopt these products. So let's get into the reviews of some of the most popular scanners. With so many options that I just show you, how do you choose a scanner? Really, this is what I think you need to think about. And it's very straightforward. What is your budget? Because if your budget is 10,000 US, there's no point thinking about the expensive scanners. You also need to think about what do you want a scanner for? And I will get into this because the needs of a periodontist who does a lot of implants is different to the orthodontist or the general dentist who does a lot of crown and bridge. What procedures do you focus on? And that relates to what your needs are. What do you need a scanner for? You need to look at software and integrations, and you need to look at the ease of use and team training. I know in Iran, it's a bit tricky with training and these sort of things, but there's a lot of training online. I run it through the Institute and also through your sales reps. I recommend, look, if you guys haven't heard of the Institute of Digital Dentistry, that makes me a bit sad. No, I'm just joking. But if you want to look into scanner reviews, go into our website. We have reviewed all these scanners in detail, instituteofdigitaldentistry.com. You can go to our blog and look at all these reviews, and we've released them for free. But let's start getting into it. So one of the most popular scanners in the world is the Cerec Prime Scan. This is a scanner I use very often in my practice because I do a lot of crown and bridge. You can see on my Instagram, I always post about crowns and what I'm doing day to day. Now, the Cerec Prime Scan is a premium scanner. This is one of the most expensive scanners on the market. It's very fast. It's got a good AI. And what the AI does in scanners is the stitching, making sure the scanner stitches well, making sure that any soft tissue is removed. Cerec Prime Scan, the take-home message is it has the best workflow for same-day dentistry. It is much better than any third-party milling machine. And the reason being is not the scanner itself. The reason being why the Cerec Prime Scan is so good for same-day dentistry, as you see here. This is a single visit crown. This is routine dentistry in my practice now. Very easy to do, and a patient can walk away with a high quality ceramic restoration. This is EMAX within an hour and a half, 2 hours. And this is not to do with the scanner itself. It's to do with the workflow. The scanner itself, Cerec or Dentsply sell the Prime Scan as a scanner alone, and I don't see any point in buying it as a scanner alone. But when you combine it with the milling machine and the software, it is an excellent workflow for same-day dentistry. And the company knows this. This is why the chairside software is locked. You can't use the chairside software with any scanner except Prime Scan and OmniCam, the old Cerec scanners. So this is really the strength of Cerec. It's same-day dentistry. And again, the workflow is excellent. This is an example of something like this. Simple margination. And what you can see is the software does all the work for you. This is the beauty of Cerec. I mean, there you go. The software did all the work. Of course, this is not a perfect crown right now. It needs some adjustment, but I would say 90% of it is perfect. You can see here, I start to play around with the embrasures, the emergence profile, but the milling and everything is very simplified. So really the awesome features of Cerec is same-day dentistry, it's fast speed, and it offers a complete restorative workflow. The downsides of Cerec is that it's expensive. The entire Cerec system, the latest one, Prime Scan and Prime Mill, costs about 120,000 US. So this is a very significant figure. And I know in some countries, this is just not economical. Different countries have different buying power. The other thing that's quite interesting about the Cerec is apart from same-day dentistry, the Cerec itself doesn't really have many apps or software. It's just excellent at same-day dentistry. That's what it's powerful for. But for smile design, for orthodontic simulation, it doesn't have these things. The other thing is it's quite large. So this is the old Cerec on the right. This is the Cerec Omnicam. This is about 10 years old now. And this is the latest Cerec. And you can see they made it much larger. And as you can see here, all these different scanners, this is arranged by cost. On the left there is the Cerec Prime Scan, second to the left. And you can see it's one of the most expensive scanners, and it's also one of the largest and heaviest scanners. So that's really the Cerec. Then you have the 3-Shape Trios 4. This is another premium scanner. As you can see here, by the cost, it's the third most expensive scanner on the market. This is another excellent scanner. I use my Trios 4 a lot every day, and I just used it today. It's very fast, it's easy to use. It has a wireless feature, which some people really, really like wireless. It has caries detection, smile design. It has a lot of applications. And if this is important for you, this is a great scanner. The reason why people like 3-Shape scanners, guys, is the software. And this software is not included in the scanner. This is an additional cost and it has a subscription. But people like the 3-Shape CAD software. And in my opinion, their denture software and their implant studio is some of the best software in the industry. For people that do a lot of implants, the 3-Shape implant studio is excellent. If you want to go economical, you can also look at Blue Sky Bio. For dentures, their software is excellent. And also their cart, this is a 3-Shape Trios Move. You can see it just looks very aesthetic. It's very attractive. The scanner can be placed in front of the patient. It's very engaging for the patient in your communication. So the awesome features about the Trios 4 is that it's fast, it's ergonomic, especially the cart. It has multiple applications, such as the smile design video I showed you earlier in the presentation, and it has caries detection and it's wireless. The downsides, again, this is a common downside, is that it's expensive and it has no milling machine. This is a big downside of 3-Shape. Cerec is a complete workflow. You can buy Cerec with a Cerec milling machine. 3-Shape does not have a milling machine, which doesn't mean it can't be used for milling. You can use 3-Shape for producing restorations, but you have to rely on a third-party milling machine like VHF, like Roland, like these products. And the more companies you involve in this communication line, the more issues can arise. This is the only problem. We did it for years. It's not like you can't do it, but more issues can arise. The other thing with Trios 4 is subscription costs. Excuse me. With the Trios 4, traditionally it had subscription costs, so you had to pay yearly fees. But under market pressure, they changed this recently. So now under market pressure, you can opt for the Trios Omni package, which has no subscription fees. So the only thing that has a subscription is their CAD software. If you want to do implants or surgical guides or aligners, this has a subscription fee. And this is what I'm showing here. All these softwares have a fee and a subscription cost. So really, that's the main downside of the Trios 4. It doesn't really fit. If you're very keen on doing same-day dentistry, I would personally just get a Cerec. But if you like the apps and you like the 3-Shape software ecosystem, it's definitely a scanner to keep an eye on. Here you have iTero. I won't spend much time on this because I know it's not available in Iran, but just for your information, this is a very expensive scanner. It is the Invisalign scanner. I'm not sure if you guys use Invisalign in Iran. I'm probably not, but really this is the only scanner you can use with Invisalign. All the other modern scanners are completely blocked from Invisalign because the company is having a bit of aggressive competition. Apart from that, look, I don't really recommend this scanner a lot, to be honest. So you guys aren't missing out on much. It has some nice features like the orthodontic simulation is good. But really it's the Invisalign scanner. That's what it's for. If you do a lot of Invisalign, this is the scanner you get. It's not particularly fast. It's not like 3Shape or Cerec, and it's very large. It's almost like a joke how large it is. It's too big. As you can see here, right on the left is the iTero. It's much larger than any other scanner. But really, that's all I'll talk about the iTero because it's not really applicable for you guys. The next scanner is Planmeca Emerald S. This is the latest Planmeca scanner. And this is a mid-tier scanner. It's not the most expensive. It's about 30 to 40,000 US. It's not the most expensive, but it's not the cheapest. And this is a plug and play scanner. While the other scanners have a cart, this is used with a laptop. Trios can also be used with a laptop. The good thing about Planmeca is that it is an affordable alternative to Cerec. Planmeca is also the only other company that has an entire workflow, software and milling machine. Cerec has software and milling machine. Trios has software but no milling machine. So the Planmeca system offers a cheaper alternative to Cerec for those who want to do in-house CAD/CAM, and it's pretty good. It's an affordable alternative to Cerec. The issue with the Emerald S, in my opinion, is that the software is just not as good as Cerec. Okay, so if you had the money, I would just buy Cerec. But if you're, if you don't have the money, this is an option. The software is a bit dated, and the CAD has some limitations. For example, if you have two crowns opposing each other, you can't design it simultaneously in the software, whereas Cerec you can. This is what the old Planmeca software used to look like. It's called Remixis. And you can see it looks like something from 30 years ago. Now, they did update the software. It looks a bit better now, but it's still not the nicest software on the market. Compare that to Cerec. You can see the difference instantly. So the Cerec is a better competitor in the same-day dentistry workflow, but Emerald does offer that economical advantage and the economical choice. And that's basically the Emerald S. It's an okay scanner. It's not the fastest, but it's affordable. Then we have Medit. So Medit is extremely popular. And the reason why it's extremely popular is it's very economical. The Medit i700 is 18,000 US, so it's much cheaper than all other scanners. And it's very fast. It's a scanner that competes with Cerec, with Trios. It's very fast. The best thing about Medit is the software. The scanner software in this scanner is one of the best in the entire market, and I'll explain why. The other thing is it has no subscription fee at all. This is a very good scanner for those looking for a cheap option. Medit recently released a new scanner, the i600 and the i700 wireless. So you guys may have seen the i500, which may still be available. This is a device that will be slowly pushed out of the market because the i600, the blue scanner, is the successor. So in their lineup, they have these three scanners and they are the same optical engine. i700 wireless, i700 and i600, it's all the same. And I've written an entire article about these four scanners that you can go read if you want. And this, you can take a screenshot if you want. This is a summary of that article. This has all the different features of these four scanners. The bottom line is, guys, is that the Medit scanners are lightweight, they're extremely capable, and they're economical. This is the best part about Medit. And the support is excellent. You can go on their Facebook group and they have excellent support. You can contact their support network online. It's very good. This is what I was talking about the software. So the Medit apps, like those applications I showed you, Smile Design, Orthodontic Simulator, they have a lot of different software included with the scanner for free. And this software is absolutely excellent. It is some of the best in the entire industry. Here's an example of some Medit scans that I have taken. It's good at full arch, it's good at implant scans, much like Trios and Cerec. It's not the best, but it competes with them. And it's much cheaper. Really, in my opinion, the main drawback of Medit is that it's a scanner only with no design software yet. I'm sure the company will invent a design software soon. But right now, if you want to do in-house CAD/CAM, you need to buy Exocad, which is a line, which I don't know if is available in Iran, or you have to buy 3Shape CAD software. So it doesn't have any CAD software. It's just an excellent scanner.
We have Exocad in Iran. And
Nice. Good to know.
Yeah.
Good to know. Thank you for letting me know. It's I'm a little surprised because I know Itero is not available from my understanding, and they're the same company. But anyway, yeah, if you use it with Exocad, even better. So you can use it with Exocad, you can use it with 3Shape, but it's the company itself doesn't make a CAD software. And like I said, the more pieces you include, the more complicated things can be. Now, there's so many things to discuss. You know, I can talk about scanners all day, but I don't want to keep you guys here all day. So there are some honorable mentions. There are many scanners, guys, like the Carestream scanner. This is a new wireless scanner. There's the Heron. There's the Wow scanner. And basically, apart from the ones I mentioned, all these other scanners, they don't really have a big market, unfortunately. And the reason being is that they don't do anything exceptional. They're all very good scanners, but you know, if there's a cheaper, better product like the Medit, it's hard for these companies to take hold of the market. Because for instance, the Carestream CS 3800 is a good scanner, but the software isn't particularly the best. The Wow is very small, but the software isn't good and it's hard to scan, etc., etc. The other thing that's coming, guys, is the Chinese scanners. The Chinese are going to be the #1 factor to drive prices down. This is going to be massive. All these scanners I've tested. So you have things like the Helios, you have Lawnca, Shining. A lot of Chinese scanners are coming on the market, and how Chinese compete is by price. They make it very cheap. So for instance, I've used all these scanners. You can check all the reviews. I think one of the best Chinese scanners, something that's actually a good product, is Shining 3D Oral Scan 3, the latest, is an excellent scanner from China. The others, the issue with the other scanners is that they scan fine, but the software is the key. So Chinese scanners are very cheap. The hardware is catching up to the Europeans, to the Americans, to, you know, all these other companies, the Germans. But so the hardware is catching up and they're fast enough, but the software is the issue. The software isn't quite good as these other companies. And this is what Medit focused on. They made their software so good so that it is a competitive advantage. And as you can see, look, I've reviewed all these scanners and I highly recommend anyone who's thinking about buying one, go onto our website and check. And this is another screenshot you can take in our IDS review. And we basically rated all the scanners on the market. Every single scanner, based on speed, based on ease of use, based on the software, etc. So in summary, I mean, how do you choose? If you just want something cheap and you want a cheap impression replacement, I would look into Trios 3. I would look into i700, i600, and Intra-Oral Scan 3. I think these are the best cheap impression replacements. If you are dead set on doing in-house CAD/CAM, look into Cerec Prime Scan and a Prime Mill. Or you can use any scanner with Exocad and a milling machine. But you need to look at a third-party milling machine and you need to look at a third-party software like Exocad. If you want to use Exocad, take note, any scanner will work. Every scanner on the market is open. And if wireless is important for you, there's 3 wireless options: Trios 4, Medit i700 wireless, and the Carestream CS3800. That basically summarizes it, guys. That is a big crash course of all the different scanners on the market. And like I mentioned, if you want to get into this stuff, I have a lot of content online, and I welcome any questions at all.
Dr. Hassini. Great comparison, and it was very informative because you gathered all of the information about the different scanners in one presentation. My question is, does the Cerec software a closed software?
Yeah, technically it is. I mean, if you ask
I
any
can
Cerec
hear
rep-
you.
Hello, can you hear me?
Oh, yeah, now I can hear you. Yeah,
Okay.
please.
Cerec software, they have 2 software. They have in-lab, their lab software, and they have Cerec chairside. Cerec chairside is a closed software. So the common file that all these scanners use to communicate with any software is STL. So you might hear a Cerec rep say it's not a closed software because a Cerec scanner can export STL. But if you try to import any STL from any scanner into the chairside software, you can't do it. So in my opinion, yes, it's a closed software, and they close it for a competitive advantage because they don't want any other scanner using their chairside mill. The way to get around it is to use Cerec in-lab, which is the lab software. So many users that like the Cerec milling machine, but they have a Medit scanner, they will buy Cerec in-lab and a old Cerec mill like the MC XL, and using the lab software, you can communicate with the chairside mill, but otherwise it is closed.
So is it possible to use exocad design on Cerec in lab? No.
In lab, yes, but not Cerec milling machine. So you can't use exocad to send to a Cerec mill, but you can use exocad to export a design and import it into in-lab, but you wouldn't do it that way because you don't want to accumulate software. You would just design an in-lab and send it.
Another question, if we have 3-shape, we can't use it with our chairside Cerec, we have to use it with in-lab Cerec, actually. Yeah.
If you have 3-shape, no other software will talk to a chairside Cerec mill. You have to use in-lab. And
if we have, for example, a 3-shape scanner, can we use exocad for I don't know, some kind of milling machine that is used here. I don't know the name of the machine.
So how that would work is that exocad is an open software, and so is 3-shape. They're both open software. So you can use any scanner with them. You just export STL or PLY or OBJ. These are color files. And you import it into exocad, and then you design whatever you like, surgical guide, crown, bridge, all on 4, and then it communicates with your milling machine.
Yeah. Now another question about the scanning. Some of the scanners have very large band, especially at the head. Isn't it difficult to scan inside the mouth, especially at the background, at the posterior side, like and the distal side? Isn't it difficult to scan there? Yeah, look, in theory and in reality, yes. I mean, obviously, smaller scanner is much easier. I will put it this way. I've never had the Cerec Prime scanner is one of the largest heads. I've never had an issue scanning distal. I mean, it's all about your angulation, and you usually go buccal or lingual and angle the scanner. But I'll put it this way. If I had a pediatric patient or a child, I wouldn't use the Cerec Prime scan. It's ridiculous. Like, their mouth is too small. So yes, I mean, in reality, it is a little bit more difficult. Is it impossible? No, you can definitely do it. But smaller scanners are easier to use. Yeah, another question is about do you use it for full mask, imagine full mask, crown and bridges?
All the
Do
time.
you use, yeah,
Routinely,
or
yeah.
not?
I do it all the time routinely. It's very accurate. Any tooth restoration is very accurate with a scanner. Where you get inaccuracy is when you have edentulous arches, because it's much harder to scan.
I mean, when you have a abutment from anterior to the posterior, you know, at the anterior to posterior, we have a turning. Are they accurate at this turning?
100%. So you mean like long span bridges or in the corner of the mouth? Yes, it's more than accurate. You just need to use the right technique. If you don't know how to use a scanner, you will introduce errors. But if you train about the proper scanning strategy, about how to take an accurate scan, and you identify where the areas of inaccuracy can be introduced and you reduce these, you will have no issues.
And another question about implant dentistry. Do you use them in implant dentistry with the scan bodies?
Routinely, yeah, I use scan bodies.
Yeah. So, I sometimes think that taking an impression is much easier than scanning from one side of the mouth to the other side. But it seems that it is related to actually being a professional, being getting a skill.
I think the most important thing is just practice, to be honest. I mean, of course, you will feel the impression is easier because our whole life we do impressions, you know, our whole career we do impressions. So when it's a new technology, you think, wow, this is harder. But I guarantee if you just stick to it within a few months, you will never want to do an impression again, because there's no doubt, yes, an impression may be easier for you, but it's not easier for the patient. And you will get to a point where a scan is much easier than an impression. You don't have to deal with gagging. You don't have to deal with mess, no air bubbles, no streaking, none of these issues. And like I say, I mean, my full art scan, most patients, 45 seconds, 60 seconds maximum. So it's quite straightforward.
Can the scanners, I have heard Prime Scan can scan inside the canal for 2 centimeters almost.
Yeah, I mean, look, the depth of field for scanners ranges. Some have about anywhere between 60 millimeters, 200 millimeters. It does range. But yeah, look, Prime Scan can scan very deep. I mean, I don't do a lot of cast post core, so I don't use it for that. But yeah, scanners can, if it's dry, a well isolated field, they can scan very deeply, because that's another common concern is deep margins. And this is not an issue, basically, because if a scanner can scan 2 centimeters, your margin will never be 2 centimeters. You just need to isolate the area properly. That's why people have issues, because they don't actually know good isolation or good scanning technique.
Is there any scanner to can scan beyond the gingival tissue? I heard there are some technologies that is coming that scanning beyond the gingival tissue is possible. Is it possible?
Just marketing. No, this is just marketing. This is all just marketing and fancy YouTube videos, maybe, because it's just fundamental physics. You know, we can't change how light behaves. Even any multi-million-dollar company, you know, the scanner is just a projector of light, and the light reflects and it captures that light and makes a digital impression. It can't bend around gingiva and magically come straight to the sensor. So no, if there's anything in the way of the preparation, you need to control it.
Did I get right? We have only 2 companies to have milling machines. One of them is, or they have 3 components of the CAD/CAM system. One is Cerec, and the other one is Emerald from Plan Mecca.
Plan Mecca, yeah, you're correct.
Other companies have milling machine too. Is there any other company to have?
No, it's just those two. But a lot of companies, a lot of sales rep bundle milling machines with their scanners. So they sell a Medit with a VHF milling machine or a Roland milling machine or DG shape milling machine or a Chinese milling machine. But the company itself doesn't make this milling machine.
Yeah, yeah. Okay, I think I have asked a lot of questions. Is there any question too? My colleague that introduced you to us is here. Can you come here, Dr. Makali, and he has asked you about. Dr. Makali is one who introduced you to us.
Hi, Dr.
Hello,
Ahmed Hassim.
doctor. Nice to meet you.
Nice to see you again.
Have you seen each other already?
I have seen about the question about 3D shining oral scanner.
They have a lot of customers. I have seen always it is written on your website. Someone is coming and joining to you. To your
With Shining, it's really good scanner, doctor. It's really, really good. I mean, it's one of the, I would say, the top Chinese scanners. So definitely anyone who's looking at cheapest possible viable product, I would suggest look at Shining 3D, Oral Scan 3. Don't buy Oral Scan 1 or 2. It's rubbish. The latest one. Or Medit just released their latest scanner, i600, which is also excellent. And they released that at a very aggressive price because they want to compete with the Chinese scanners.
And the type of the light, is it white or laser or another?
It varies. It varies a lot based on the optical technology used. So basically, there's two different types of scanner technology: triangulation or confocal scanning technology. And we don't need to get into the specifics because realistically, for dentists, it doesn't matter. They both work. But sometimes they use structured light, sometimes it's LED, these sort of things.
Thank you so much. So again, I want to tell you that it was very great, a very informative lecture. We hope we can see you again on our webinars. And now I know that you are very tired from the beginning, from the morning and up to now that you have work. So please give our hello to your fathers and brothers. And thank you, father and brother. And thank you so much for being with us.
Thanks so much for letting me be here. And I really do appreciate it, guys. It's a great honor. And I wish you guys all the best. I hope we can run into each other one day in a conference or something, because it's a small world. But all the best and stay safe.
Yeah, thank you so much. See you soon here around.
I hope so. Maybe one day I can come to Iran. Who knows?
Inshallah. Inshallah.
Thank you, guys. Have a good one.
Coming you warmly here.
Thanks a lot.
Our next lecturer is Dr. Habibzadeh from Tehran University of Medical Sciences. Dr. Habibzadeh, thank you so much for accepting our invitation. Dr. Habibzadeh is Associate Professor, Department of Prosthodontics, the School of Dentistry, Tehran University of Medical Sciences. Her topic is digital workflow for removable prosthodontics. Thank you so much for being with us, Dr. Habibzadeh.
Hello, Dr. Fari.
Hello to you.
Can you hear me?
Yeah, everything is okay. We can see your presentation too.
Okay. Good morning, everyone. Happy to be here today with you. I'm sure you have enjoyed the previous presentations. My presentation is about the digital workflow for complete dentures. Today, we're going to talk about direct digital manufacturing very shortly, very briefly. We see the history of complete dentures, which are manufactured by CAD/CAM technology. We see the advantages and disadvantages of these dentures. And we'll have a look at the commercially available systems that are used to fabricate CAD/CAM dentures. And then we go over the physical properties of the material which is used in the system to see whether the system can compete with the traditional and conventional ones. As we all know, direct digital manufacturing was first introduced to dentistry in 1971 by Cerec, and nowadays we have different kind of CAD/CAM restorations available. We have inlays, onlines, endocrowns, different kind of fixed restorations, implant-supported restorations, even maxillofacial processes, all manufactured by CAD/CAM and digital technology. But when you see the complete dentures are the last to join these digital revolution in dentistry, and that's because of the nature of the mucosa and supporting structure that we're dealing with. We have a process called border molding, which cannot be processed through intraoral scanning, and yet we have several challenges in fabricating these CAD/CAM dentures. So that's why they're the last to join the digital revolution. The procedure is actually the same as with other CAD/CAM restorations. It consists of data acquisition, processing, and fabrication of the model. Previously, we had closed systems, which means you had to have the same scanner, same software, and same milling machine of the system. But now, fortunately, most of our systems are open. It means that you can have an intraoral scanner from one company and then use the data with another milling machine or a design software from another system. So these systems are open and they provide us with various options. Scanning devices are categorized into these two categories: the intraoral scanner and scanning of the impression or cast. Use of intraoral scanner is actually very preferred by the patient and the dentist itself, but with CAD/CAM dentures, we have still some challenges that we're going to after at the end of this presentation. So from today that we're standing here, we still have scanning of the impression or cast. We need to have a lab scanner to have our impressions taken traditionally and conventionally, and then scan them through a lab scanner. Again, we have two techniques to fabricate our dentures. We have the subtractive manufacturing, or SMT, and additive manufacturing, or AMT. I'm sure you're all familiar with these two terms. With SMT, or CNC machining, the shape of the model is usually made from a block. It can be a composite block, a ceramic block, or in case of dentures, pre-polymerized acrylic block. But we have several limitations with SMT. The first one goes back to the milling machine. It has restricted motion capability, and not all complex geometries are able to be fabricated by this technique. And the second one goes back to the material. It has to be tough, sterilizable, and hard. But with AMT, which is also called as rapid prototyping, freedom fabrication, and e-manufacturing, we can have unlimited geometry options. We can have finer detailed reproductions, faster speed, mass production, and we have lower material waste. So this one is actually has less limitations, but with CAD/CAM dentures, we're not so good with AMT. We'll see in the upcoming presentation. So going back to the CAD/CAM denture, we see that in terminology, we have that the digital denture is a complete denture, which is created through CAD/CAM and CAE, which is computer-aided engineering. And the first actually article to validate the clinical procedures of a CAD/CAM denture goes back to this article, which was written by Goodacre and his co-workers, and they used pre-polymerized PMMA and a 5-axis milling machine to produce the first CAD/CAM denture for patient. And through this presentation and article, the clinical procedure of CAD/CAM denture was validated. So comparing the conventional dentures with the CAD/CAM ones, we see that in order to fabricate a conventional denture, we usually have 5 steps. The first one is making the preliminary impressions. Then we have the final impressions. In another session, we have to have our records. Dr. Fight, am I going too fast? Do you think I'm going too fast? I can slow down. Can you hear me? Okay, then everything is fine. Finally, in the 4th session, we have the trial placement of the wax dentures. And if you're lucky, in the 5th session, we're going to give our patients the dentures. But when it comes to digital dentures, the manufacturers claim that we can have our dentures in only 2 appointments. So the first one, the patient comes and all of the data is gathered: impressions, jaw relations, occlusal plane orientation, shade, and mold. Everything is gathered in the first session. And if you're lucky, you're going to have a denture in the next session. So that's gold. Therefore, the advantages of a complete CAD/CAM denture are, first of all, we have 2 appointments instead of 5 in a conventional denture. Then it's the fabrication fee, which is somewhat comparable to the conventional dentures. Another advantage is the ability to provide our patients with these data to use another spare denture or replacement denture, surgical or radiographic template. You can have all these information stored and then use them only to fabricate several options. And the other thing is that the material that we use with CAD/CAM dentures has a superior feed strength, rest residual minimer, and Candida albicans, which is usually a problem in our conventional dentures, adheres less to these dentures. We're going to talk about the material later in the presentation. But along with the advantages, we also have several disadvantages. First of all, we need an experienced clinician. So when all of the data is gathered in only 1 session, including the impressions, records, and everything else, the clinician has to be very skilled. Secondly, usually a clinical remount is needed with these CAD/CAM dentures, and that's because the setting of the teeth are ritual. We need temperature-resistant impression materials because we're going to transfer our impressions to the lab so that we can have these lab scanners. And then usually the lack of a trial placement is acquainted with a lot of problems, so it is highly suggested that we have a trial denture in this technique as well. All right, let's look at the commercial available CAD/CAM complete dentures. This list is actually completing every day. So we have the Avedon digital dentures, which are actually the pioneers, Dentka, Ivoclar digital dentures. Nowadays, we have the Amangrabach company providing us with CAD/CAM dentures, Ceramic full denture systems, Vita Bionic, Baltic denture system, Dentsply, Valand, and Holynex teeth. And as I said, more and more companies are now being interested in providing CAD/CAM dentures. I have chosen 2 of these systems, one which uses the SMT or subtractive technique, and the other one uses AMT, printing faces and then bonding of the teeth. And we'll compare and see how these procedures go. So with Avedon digital dentures, which were introduced as the pioneers of CAD/CAM dentures, we can have a milled denture base from pre-polymerized block of resin, and then the individual teeth are bonded to this. Or we can have another option, which is a monolithic Avedon denture, which is completely milled from 1 block. So the teeth and the base are both milled at the same time. This system can provide us with complete dentures, provisional dentures, single arch complete dentures, conversion dentures, immediate complete dentures, bracket bases, implant supported overdentures. So you see that with only 1 impression taking and gathering the data, you can have all these options. Even you can have scanning guides, verification jigs, and bone reduction guides. We usually have 3 appointments with these dentures. The first one, as I said, is impression technique, jaw relation reports, the orientation of the occlusal plan, and selection of the tooth mold and shape. Then in the second session, we'll have a trial denture.
Sorry, Dr. Hype said that we can, you are freeze. It seems to be have internet connection problem. I think you freeze. Dear audiences, unfortunately, we have internet disconnection, and so it takes a while to fix it. Let's talk about the next presenter. The topic that is very, it's very, okay. Dr. Habib, please go on.
Okay, sure. We were talking about evident digital dentures, and as I said, we have a special introductory kit in each and every of these systems so that we are capable of gathering all of our data in only one session. So with evident, we have these thermoplastic impression trays. We have a special device called the anatomic measuring device, which is shown in this picture in the middle. And we have selection tabs. Can you close this down, please? Hide it. Thank you. I was going to close screen. Thank you very much. Okay, we talked about the kit, as I said. And with the use of this kit, we are able to take our impressions, and the material which we usually use are the polyvinyl siloxane. We can have the regular or the light body. And then we use these AMDs to register vertical dimension and also the central relation record. So lip support, midline, the orientation of the occlusal plan, everything can be gathered with this AMD. So it has a centrally located stylus, which serves as the central bearing pin, and we can have the central relation record via Gothic arch tracing, and this part of the AMD is used to adjust the lip support. So you don't need another session to adjust the lip support. We usually fill this AMD with recording material and we secure it in the patient's mouth. And then OVD is determined in a usual manner. For example, here we have the Niswinger technique for registering the OVD. And then we'll have the CR, as I said, with Gothic arch tracing. And these shade tabs are used to select tooth mold and also shape. So we're still in session 1. We have our final impressions. We have our BD, CR, and the intraocclusal records, all of them, shade tab and shade mold. All of them are here with us. So we send these to the lab, and from these, the technician usually provide us with the border of the denture and virtually sets the tooth. So in the second session, we usually have a trial denture with which we can check the aesthetic, phonetics, functional components, and everything else. And if the patient wishes to move anything, for example, aesthetic or phonetic, or etc., then we can make these virtually in the software. So finally, after all these information is collected and modified, we can have a basis printed, this is milled from blocks of pre-polymerized acrylic. And these bases are provided like this with the recess into which the teeth are bonded. So this is how the teeth are bonded. And in the third session, our patient will have his or her final denture. Along with these technologies, we also have the 3D printed complete dentures, and they're showing promising short-term clinical performance. But of course, data on these dentures are not as much as the previous ones. We have a system called Dentka, which is like the pioneer of printed complete dentures. And in this technique also, teeth are bonded to the base is printed and the teeth can be bonded to it, or we can have another denture in which the teeth and base are both printed. It also has a starter kit and special instruments. Again, it provides us with the ability to register all of our data in the first session. We'll have our final impression with these trays, and we'll have the record. So the anterior and posterior part of the trays are separated, and the anterior part is somewhat like the AMD that we already talked about with other digital dentures. And then we use it to adjust the vertical dimension and also capture CR. So again, this is sent to the lab and scanned. The teeth are visually set. We'll have a trial denture in the second appointment. And finally, the bases are printed here. And the teeth are also printed, or they are provided. For example, you can use the commercially available teeth, and then these two are blended together. And finally, in the third session, we'll have our dentures polished and ready for placement. So this was a brief review on two of the systems, which are very popular nowadays. We also have the Ivoclar digital dentures. You see that the blocks are here bilayer. We have special blocks. And then we can mill our dentures, monolithic one. For example, we can have the bases and the teeth both at the same time printed, milled. So these special blocks are used to provide us with monolithic CAD/CAM dentures. We have the Vita company providing us with these CAD/CAM dentures and several other companies. But let's go to the physical properties of these dentures. Let's see if they are worth it so that you can buy an Intra-Oral Scanner and you can have all these instruments in your office. Are they worth it? Are they providing us with dentures which are as good as the conventional ones? Okay, there are several features that we need to go over. First of all is the wettability or hydrophilicity. We have several articles here, and they're all suggesting that the new material which is used for these CAD/CAM dentures is more hydrophilic and it has a lower contact angle than the traditional one. So it is either good for patients with salivary dysfunction and also has the advantage to be less susceptible to microbial adhesion and a less chance of stomatitis and Candida albicans adherence. Another concern that we always have with our dentures is the residual monomer. So we are avoiding this and we want to reduce it as much as possible. It just causes porosity and it causes adverse reactions in the soft tissue. So with the CAD/CAM dentures, we have high pressure and temperature. Therefore, we have less porosity and less residual monomer. And this is another one of the other advantages of CAD/CAM dentures. How about surface roughness? Of course, we have surface roughness in each and every material. We have it with the conventional technique and we have it with the CAD/CAM ones. And the problem with the surface roughness is that it causes surface staining, plaque accumulation, and also bacterial adhesion. With the CAD/CAM dentures, the quality of the milling machine and the milling process determines that whether we have surface roughness or not. And when we look at the articles, we see that the surface roughness of these new dentures are comparable or even less than the conventional ones. How about the adaptation? Do you think the adaptation of these dentures is better than the conventional ones? we go over literature and we see that with the conventional dentures, we have a volumetric shrinkage of PMMA because we use either silk or heat cure PMMA. But with these CAD/CAM pre-polymerized blocks, we actually have more accurate and reproducible denture fabrication. So it seems that the fit and adaptation of these new CAD/CAM dentures is even better than the conventional ones. Again, these are the literature that I found, and they show that the CAD/CAM dentures have a better fit, they are more accurate and more reproducible. Between milling and 3D printed bases, of course, the milling ones have a better adaptation, and the printed ones might show some problems, especially on the posterior ridge crest and buccal shelf area, and therefore they might need some clinical and chairside adjustment. But with the milled bases, usually the adaptation is very uniform and actually very good for our patient. Here again, we have a systematic review of the accuracy of digital dentures, and we see that the greatest misfit with these dentures is usually in the intaglio surface of PPS and the border seal, and that's because some of our colleagues do not use conventional dentures, conventional impressions, and they use the intraoral scanners. So putting these all together, we see that the CAD/CAM dentures are a better choice for those patients for whom retention is the primary concern. Okay, we have some problems with teeth movement with these dentures because everything is set virtually, and we usually do not have a trying, or if we have, it's just a monolithic denture. So even after processing of the bases, for example, printing or milling them, putting and bonding the denture teeth might be somehow rearranged from the original one. And therefore, literature suggests that monolithic CAD/CAM dentures are more accurate with regards to tooth movement. The solution to this problem is that most of the time with digital dentures, either CAD/CAM ones or printed ones, we need a clinical remount session. So after you give this to the patient, you'll have new records and remount your denture, and you can have the processing errors and those errors related to bonding of the dentures eliminated. We usually don't have much problem with color stability and sustainability of these new dentures, and even literature suggests that with these dentures, the stain gathering and the color stability is actually better. Again, the monolithic dentures, the monolithic CAD/CAM dentures are the best with this regard, and usually have less stains on these monolithic ones. The printed bases have shown maximum color changes in literature. And with the flexural strength and fracture toughness, we usually have no problems with these new dentures. The material that we have is extremely tough and hard, and we have no concern regarding their flexural toughness. So if you want to put these all together, we see that it looks like the physical properties of these CAD/CAM dentures, especially the milled ones, are superior to the conventionally processed PMMA. How about patient satisfaction? As I said, these are really new and we don't have much information on their clinical usage, but the limited information that we have and the limited literature suggests that the overall satisfaction and assessment is actually good with these dentures. Some of the problems that our patients reported are lack of retention, which goes back to the scanning process, inaccurate vertical dimension, and incorrect centric occlusion, which are all being taken care of by a clinical remount. In another study, the reporters reported that 40% of these dentures needed a reline. Okay, finally, what we have today and the hot topic about these CAD/CAM dentures is whether we can have our impression taken via an intraoral scanner, or we have to stick to the conventional impressions and use a lab scanner. The problem that we have is that with the use of an intraoral scanner, we have a mucostatic impressions. But when we do the bottom molding and we use traditional and conventional ways, we usually have a functional or mucodisplacive impression. So is it good or bad to have a true mucostatic impression? We have no border molding in intraoral scanners. Therefore, the retention of the final processes and especially the seal of the denture might be compromised. We have several articles that have used intraoral scanners to capture the impression of CAD/CAMs dentures. The process is usually successful in maxilla. It usually takes less than 2 minutes, but for mandible, because the mucosa is very displacing and because of the inherent quality of the mandible, usually use of an intraoral scanner is not very successful. And others have suggested that instead of having the impression with an intraoral scanner, you can have your trial denture base realigned or do the border molding on the trial denture base to correct your border molding and the periphery of the dentures. So another consideration is that rescanning usually decreases the trueness and precision of intraoral scanners. So rescanning is not usually recommended. We have different scanning pathways. For example, in the upper image, you see that we have this S-shaped scanning pathway, and in the lower one, you see that we can have a buccolingual or lingual buccal pathway to capture the mucosa and the impression with an intraoral scanner. Another important thing is that we always have to correct the border when we use an intraoral scanner. And the best way to do that is to do a reline with the trial denture. So in the second appointment, when you have your trial denture, you can functionally reline the trial denture and then send this back to the lab to be scanned and correct your border with this technique so that you don't have the problem of retention or seal or stability with your new denture. So if you want to gather these all together, again, you see that intraoral scanners are now beginning to be used to capture the impression of digital dentures, and they're showing promising results, but they still are vulnerable to inaccuracies. And especially for the mandible, the suggestion is to use the traditional and conventional impression and then send it to the lab to be scanned and do the rest of the procedure digitally. All right, thank you everyone for joining us today. I would like to take this opportunity to thank my colleagues here at Tehran University of Medical Sciences for organizing this course, especially Dr. Farid and our honorable colleagues at the International Affairs, especially Dr. Mihashemi. These are my contact information. I would be more than happy to help if there are any questions.
Thank you so much, Dr. Habibzadeh, and thank you for accepting our invitation and very useful and informative lecture. I hope that our audiences have enjoyed it, and just I want to say Gothic art tracing is very hard. I remember from my student time, and again, that if we want to use Gothic art tracing, it doesn't seem very appealing for me, at least. So thank you, and I hope you have a good day. And for now, goodbye to you.
Thank you very much.
Our next
with the rest of the course, Dr. Farid. Thank you.
Thank you. Okay, our next lecturer is Dr. Mahnaz Arshad, Associate Professor in Department of Prosthodontics, School of Dentistry, Tehran University of Medical Sciences. Her topic is patient-specific subperiosteal implants. It seems a very interesting topic, and we will be happy if Dr. Arshad share his screen. You have shared? Okay, okay. So as you know, implants is now a very common practice in dentistry, but we have some problems with patients, with maxillofacial patients, with traumatic patients. Patients have trauma in one part of their mouth, and placing implant for them is somehow hard, and it having a specially designed implant for this patient is a concept that helps them a lot. That's Dr. Arshad is going to talk about it for us, and I'm sure that you will enjoy this topic a lot. Making or designing subperiosteal implants needs not only, I think it needs, in addition to Cbct designing software in the actually your CAD/CAM system. Yeah, no, okay, and it seems that it will be very helpful for the patients, and that they need a lot of attention for their treatment. Loss of plenty amount of tooth structure, and retaining the prosthesis is very hard in these patients. And they don't have a normal natural supporting tissue, so it's very hard, and it takes actually the point is it is helpful very much for the quality of life, and of course it has some points to consider when you are designing. I think one of the most important is how to cover it with a soft tissue. It is not just forming the arch, and the important part is how to cover it when it is not, there is not enough mucosa to do that. And also the integration of subperiosteal implants with the bone is I think is a point of concern, and I think that Dr. Arshad is going to talk about these points too. And the other point is sometimes we hear about patient-specific actually titanium mesh, and perhaps these subperiosteal implants is something like these titanium meshes, but designed for the patient, and it remains for a long time there. And the most important thing is to be able to also integrate with the patient's bone and be covered for a long time with mucosa. I think the problem with most of these subperiosteal implants is the mucosa it recedes, and the implant becomes exposed, and that is a problem. It is a solution, but this solution needs a lot concerns and a lot of knowledge from the standpoint. Okay, and Dr. Arshad. Okay.
I mute my microphone.
Hi, everybody. I'm very appreciated to be in this special congress with my colleagues. And thanks, Dr. Fari, to invite me to participate in this symposium.
Thank you for accepting our invitation.
Thanks. I want to speak about the special subperiosteal implant that nowadays is very common in the reconstructive patient. Okay, you know, we have a very different patient and that they lose their teeth, and the implants technology help them to come back to the usual lives. And you know, the goal of modern dentistry is to restore normal contour, function, comfort, aesthetics, speech, and health of the patient. And with the implants, we can achieve to all of these goals. But when we have the special patients that they can't use of the industrial implants, usual implants, because they have a very atrophy reach and that they can't put implants there. In the past, we used the regenerative surgery. For example, we used the allograft from the iliac to harvest the jaw and then use the industrial implants. And you know, the fail ratio of these implants is very high, and we have a donor size and the compromised this side. So nowadays, the subperiosteal, the new design of subperiosteal implant is come to the reconstruction of these patients. You know, we have the transostal implants, subperiosteal implants, and endostal implants. The subperiosteal implant, transostal implant was used in the past, but because of the problems, we stopped the use of them. And the endostal implant is common nowadays. So we have some special patients that they attack to trauma or cancer or long-term edentulous patient, or the patient that failed the endostal implants and they haven't any adequate quantity and quality of the bone. So what we can do for them? This SPI implant or subperiosteal implant is one of the implants that we can use. In the past, they made them with chrome cobalt and titanium alloys. So the failure rate of them, because of the processing, of the design, and the material used is very high. Contraindication of using subperiosteal implant is the progressive bone resorption because of calcium metabolism disorder, poor quality cortical layer, and recent radiation of the head. But in a new technology of subperiosteal implant, and now it is, for example, 5 years until now, we can decrease the failure rate of these implants when we use it in the reconstruction of the severely atrophic jaw patient. A framework that we designed especially, also known as cortically supported individual implants or patient-specific implants. This is the picture of the past subperiosteal implant that made from nickel, chrome, titanium alloy, and they invested and waxing up, so that 56% of the implants actually attached to pre-implantitis and fell. But now the digital revolution of the manufacturing of these implants and new processing software, modern fabrication technique, CBCT or CT 3D information on patient bone anatomy, and use titanium grade 23, enhance the cerebral rate of these implants, and help us to reconstruct the severely resolved patient with these implants. So, the framework design principle is for fully edentulous and partial edentulous patients. Framework design, the previous subperiosteal implant is directly positioned on the alveolar crest, but nowadays we enhance these implants. You know, this is the kind of subperiosteal implant that in 1982 linked to mandibular subperiosteal implant. But nowadays we change the design and enhance the cerebral rate of them. We can design the subperiosteal implant in a one-piece or segmented design. So we must use 1.4 to 1.8 pitch, and it have a it had a three main parts: the pose, the body, and the wing. So you can see the position of the pose. That is, we must have some decision on the position of the pose, because if the pose is very near to each other, we may attack to dehiscence. The basal frame position is important, and the design of that to make sure that we can have a chance if the one part of these implants attack to fail, we can change our treatment plan. The fixation screw is designed by the software and with spatial position and determination of appropriate length and fixation screw. And the platform shifting is another thing that is very important in this design. We must polishing the perimucosal extension, because this is near the soft gingiva, and we want to have a very close attachment with this titanium and gingiva. And maybe the pores are removable or are not removable. I explain it much in the next slide. And the wings, nowadays the wings are shortened. We just need two screw hole, and we just screw one in a one hole. In a partial edentulous, you see the picture of our patient. When such patient come to our office, in the past we use bone regeneration technique, and if we don't want to have an iliac graft and the complication of that, we must use the nerve repositioning surgery, or we must use the short implant. All of these situations have some complication, and when we want to avoid these complications, we can use subperiosteal special implant. For these patients, we can scan the patient mouth and use virtual diagnostic mix-up and then design a model, or we can take impression and make the radiographic scan with the sulfate barium, and then take the 3D CT scan with some special software. For example, we use Materialist 2 in this patient. We designed the subperiosteal implant upon the best place of our teeth, the length of these, and the extension of the subperiosteal implants. So we can design it for example, in segmented form as for the partial edentulous. And with the fixed abutment, you see, we have the fixed abutment, so we must understand the position, the exact position of the teeth. So we must have a prosthetic pre-surgical designing, and we have an exact treatment plan for this patient. After that, you see the 3D radiography of this patient and the designing of the abutment. This is the final element analysis of this subperiosteal implant, and that show the weakest spot of these implants are in the arm, and we must pay attention on designing of the arm. This is our patient, my patient, and we designed the implant with the material is true, and we printed the subperiosteal implant with titanium alloy 23. And after that, we scan the implant, the finish line, the abutment, and you have this is the exact exocad STL files, and we have these before the patient going to the surgery. So we can design the temporary or permanent bridge and crown with this file. After that, we sterilize with gamma or autoclave B or ethylene oxide, and we do the surgery, and we put the subperiosteal implant in the patient's mouth. After 2 weeks of surgery, you see the illness of the gingiva, and you see the implants. And this is the final restoration of the patient that make with the steel file that we capture before the surgery. So we have the fully digital processing, and we don't use the impression at all, because all the procedure is in an exact way, and it's very precious. You see the postal radiography of the patient, and you see the exact insertion of the crown and the insertion of subperiosteal implant and rehabilitation of the such difficult cases with the subperiosteal implant. Another design of the subperiosteal implant is the ball attachment, and you know the ball attachment have some disadvantages, that the roughness, the wear of the ball, and the decrease of the retention, and the powers of the ball, cap retention, and dimensional accuracy. So we design a ball. We also design a ball attachment for another patient that you see in these. The 63 years old woman that broken the left side of the body of her mandible because of the atrophy of jaw. So we designed the SPI for this patient, and with the SPI, actually we fix the jaw and rehabilitate the jaw with the ball attachment. You see the size of the attachment here, and after that we make the overdenture ball retaining overdenture for her. But this is my design. This is my special design, and I like this design. I attempted it because this design have a fixed abutment, so we don't have any screw loosening, and we parallel the abutment before and we parallel the abutment with the software before the making it, before the surgery. And so this is the very precious method, but it means it needs the consultant, prosthodontics consultant that guide the abutment, inclination, and position. But if we design the abutment in a very good manner, that's easy for us, and the treatment is so easy. And this is the connecting bar, and Dr. Moller, the one who worked in the subperiosteal implant very much, likes these structure and work in this manner. And you can see his articles about this method. Another design is the connection design, and we can make the correction in subperiosteal implant and use the abutment, so we can manage the inclination and the length of the abutment in this method. And titanium grade 23 that we use in the subperiosteal implant is very biocompatible, and the ultimate standard is 920 megapascal. That's very good, and no fatigue damage in the mastication sites was seen. Several rate of mandibular subperiosteal implant successful, and like the implant, the usual endostall implants. The clinical complication of these implants is infection. That's also like the stall implant, early and late implant exposure, bone resorption, absence of osseointegration, fistulation, implant mobility, patient discomfort and implant failure, pressure necrosis, failure of many subperiosteal implants because of continuing bone resorption. So we must decrease these elements that make the implants fail. For manufacturing subperiosteal implants in a classic way, they first surgery, and then after that they take infection and the waxing cast in corn chloride or titanium finishing, surgery, and then they make the impression from the subperiosteal implant and waxing them and make the final restoration. But nowadays, with the digital dentistry, we take the impression with scanning before the implants insertion in the mouth. Another case that I want to introduce to you is for fully dentulous patient. He had installed implants about 10 years ago, but all of them were failed because of the aggressive periodontitis. So the jaw is very resolved, so they can't use another installed implant. He came to my office, and I designed the radiographic scan for him. So he captured the 3D CT. That days we use CT, but nowadays, that days we use Cbct, but nowadays we use CT because it's more exact. So after he captured the Cbct, the 3D analysis of the jaw and designing of his jaw is done, and upon the best position of the teeth, we design the implants and the structure and the pose. And after that, with additive manufacturing, we from the titanium grade 23, we make the special subperiosteal implant that you see the procedure in this slide with SLM device, multi-laser machine that printed with the additive technique, printed the subperiosteal implant with the additive technique, and You see the material, that's the highest strength to weight ratio, perfect fatting behavior, outstanding corrosion resistant, and biocompatible. And the advantages is we can form the complex geometry with that, and it's have a process structure, so the weight is less and cost is efficient, and the varying mechanical properties, high accuracy up to 30 micrometer. So the procedure is after the surgeon requires patient CT scan, the hard and CT soft tissue DICOM file sent to the manufacturer, and the manufacturer with the prosthetic prosthodontist design the subperiosteal implant, and after the approval of the surgeon, it's the manufacturer. And then it's sent to our office. We check it in the theoretical model of the skull. We scan it and then send to the manufacturer to clearance room that they are sterilize their subperiosteal implant, and then send to the surgeon, and the surgeon do the surgery. And after that, we check the patient and deliver the temporary restoration, and then after 3 months the final restoration was delivered to the patient. So in this patient you see the CT, Cbct 3D image, and then the designing of the upper jaw and the designing of the subperiosteal maxillary implants, and after that the printed subperiosteal implant that was sent to our office, and I check it in the skull, and the surgery procedure that you see, and the final reablution of the soft tissue, and you see the post, and this is the temporary restoration that was delivered to the patient. So the patient is relaxed because the social behavior or for the mastication. After 3 months, we make the final zirconial core for the patient and check it in the mouth, and then the final restoration full ceramic zirconial bridge is delivered to the patient. You see the smile and the front page of the patient, and the patient satisfaction you see here. This is the final radiography. You see this is the first picture of the patient and the atrophic jaw. This is the temporary restoration, and this is the final restoration. And these technology rehabilitate the patient in a very good way. Another patient that wants to introduce to you is the patient with the tumor, amyoblastoma, in the right side of the body of the mandible, and the surgeon said to him that they must do the surgery and cut the jaw, the right side of the jaw. So the patient is very depressed because of the smile, because of the appearance. They referred him to us, and we designed the subperiosteal especially for him. And you see, this is the cutting surgery line. That's so we cut the patient jaw, and we designed the subperiosteal implant special for this patient, that it makes the chin and the body of the mandible for the patient also, and it have some abutment for the patient tooth. So the subperiosteal implant was made, and you see the temporary crown before the patient surgery. So in the operation room, they put the subperiosteal implant, and after 1 week, we deliver the temporary restoration to forming the soft tissue and for the patient. And after 3 months, the resin model of the final restoration was made, and we check it in the patient mouth, and then we deliver the final restoration, fully ceramic zirconia bridge to the patient, and you see that appearance of the patient is actual, is normal, and the patient satisfaction is very high. So I delivered this patient restoration about 2 days ago, and actually I follow him and report the survival rate of these, but the satisfaction and the patient quality of life is very high. I thanks to my dear colleagues and dear friends that listen to my lecture. Any question, you can find me at Dr. Mahnaz Arshad Instagram, or you can mail to me.
Thank you so much, Dr. Arshad. It was very interesting. Can you hear me? Dr. Arshad, can you hear me? Can you hear me, Dr. Arshad? Thank you so much for your very interesting presentation. Can you hear me?
Yes, I thank you. I appreciate
okay.
for inviting me to this special symposium. It's my honor to be as a speaker in this symposium.
You're welcome. We are honored to accepted our invitation. It was very interesting, and I think it helps patient a lot for his quality of life. And because you have done plenty of these cases, it would be very interesting if you report the result after some year follow-up. We wait until you tell us after follow-up what happened to the patient. Okay.
Thanks.
Okay.
Thanks a lot. But the first 2 patients we followed about 3 years, and it's have a good result. But the last patient we delivered, for example, for about 2 days, and we almost followed and report the results.
Okay. Was there any exposure of the implant Subperiosteal framework? Do you have such a?
Yes, we have exposure of small body of the implant in the first patient, in the full mouth patient, but we put the patient in oral hygiene and irrigation, so we don't have any extension of the exposure of the another complication, but we follow the patient every 6 months.
And so thank you so much. It is almost 1 o'clock. I think the audiences now are enjoyed from the lectures. I enjoyed at least all of the lectures. Today's and yesterday's lecture were excellent. So after saying that, we wish you the best day, and we wish you to be safe. Say goodbye to you. Goodbye, Dr. Asha. Bye.
Bye.
Thank you, everybody, for joining us and being with us. We have tomorrow again another sessions. Tomorrow is mostly about the aesthetics, and we hope see you tomorrow morning at 9 o'clock Tehran time again. So everybody, goodbye.